All right, guys, we're going to get started in just a moment. I want to welcome everyone to our webinar, Understanding Medicare, Medicare for Chiropractors, being presented today by Lisa Maciejewski-West. I'm not going to reintroduce her with her bio. You heard all of that last week, but thank you guys so much for joining us for part two. If you haven't typed in the chat box, type in your name and your license number, if you where we have that. A few announcements. This is being recorded, so you will be able to revisit this recording. You'll receive 4 hours for part two. You received 4 hours for last week's webinar, and you will be getting a survey after the fact. We want to know what you thought of today's webinar. But a few other things I do want to mention. Uh, if you're not a TCA member, I would encourage you guys to join. You save off your attendance at our conferences, and it brings you into a great community of chiropractors, and we would love to have you as part of TCA. We are going to be offering our TCA West Texas conference that is going to be on March 27th through 28th. That is a in-person event in Lubbock, but also a hybrid event if you want to join virtually. So you can complete all 16 of your CE hours online. That's the only event during the year where we do that. And I do want to plug Lisa is going to be teaching a 2 hour session on artificial intelligence that's going to be incredibly relevant to your practice. I want her to tell you about what she's going to be covering there. I think that's a big thing all of us should be concerned about, in your practice. So that's going to be outstanding. So you can register on the TCA website and you'll be getting updates on that particular thing. And I also want to mention Chiropractic 26, our TCA state convention. We're going to be in Austin this year. That is going to be on June 26th through the 28th at the AT&T Hotel and Conference Center at the University of Texas in Austin. It's going to be amazing. We'll be opening registration for that in just a few weeks, and we hope to see you there. So thank you so much for joining us. I'm going to turn it over to Lisa and enjoy the webinar. Thank you so much for being here with us.
I appreciate it, Jeff. Thank you so much. And thank you, Maggie. I'm going to reduce my face so that I don't have to look at myself. But thank you so much for coming. I know that, a Saturday morning is sacred time for a lot of people. And I do very much appreciate you all being here today and spending a few more hours with me. Fortunately, it's really cold out, which is actually good for us because it probably makes you want to stay inside at least for a little while, and hopefully by the afternoon it'll be much better. But I do want to let you know that I added some content to today's session. And so the handouts that you got last week have been updated. I have posted the new handouts to the chat box, so you should see it now. It should say, there should be a link that says 2026 Medicare handouts. That is updated with some new content from today. I added some more information about Medicare Advantage billing that I think is very relevant right now for everybody, because that's a very, very challenging thing to navigate. So as Jeff said, before we get started, I did want to talk to you a little bit about the West Texas. It's probably one of my favorite conferences to go to. Number one, because it's in Lubbock and that's where my son lives. So I get to see my son, but also I just love the vibe. I love it. It's a smaller crowd. It's much more intimate, and you really get to interact in class. If you're that kind of person that really likes to interact in class, especially, Jeff can tell you they have adjusting classes, and sometimes with the big conferences, you don't really get to do some hands-on things like you would in the West Texas. But the class that I'm teaching for DCs is called AI, Your Superpower or Your Kryptonite. And it can really be either. And so I've been out teaching about AI for a couple of years now, and every year I teach it, there's new content because it is such a rapidly developing and changing field. And so it's important for us to keep up with what's going on that can help us in our practices and hurt us in our practices if we don't watch out, and we allow AI to be used against us or misused during our research on different things and stuff like that. So, without giving too much away, this is a great class to give you tips on how you can use AI and technology in general to be more efficient in your practices, to be more compliant. We're going to talk about wonderful technology now that's out there that allows you to create SOAP notes from ambient conversation that you have in the treatment room with your patients. And so I just love this class. It usually is very, very engaging, a lot of questions. And so I know that you can take it virtually, but you won't be able to engage unless you actually come up to Lubbock to hear the class live. Also, for those of you who have CAs that you need to train, you can bring your CAs up to Lubbock for this. And on Saturday, I'm doing a 4-hour CA boot camp. So it's going to be training for CAs, and I do it every year. Every year I've been teaching a 4-hour CA class up there, and we usually have a decent group of CAs that come in and learn a lot. And it's everything from front desk operations to office management, a little bit of insurance billing, coding, etc. So if you've got some CAs, and it's very economical. Lubbock, the hotel rooms aren't as much. It's just a lot. It's very nice. So anyway, hope to see some of you there. Okay, let's go ahead and get started. So last week, we basically talked about Medicare in general, we unpacked the different parts of Medicare, A, B, C, and D. We talked about the similarities and differences between Medicare Part B and Medicare Part C, so original Medicare and Medicare Advantage. We went into the compliance portion of Medicare as far as chiropractic coding compliance, and we looked at the different elements in which Medicare justifies medical necessity for chiropractic treatment. Of course, chiropractic treatment by Medicare standards is limited to manipulation of the spine to correct a subluxation, and we talked about what that means. And we discussed some of the documentation aids that you have and what you need to have present in your SOAP note for a compliant chiropractic note. I was telling Jeff and Maggie that if we have some time at the end of this session, because I'm really not sure, this is normally a session that I do live, but because we don't have as much engagement, with questions and answers, this may only be 3 hours, but I do have some bonus content that I'll be presenting maybe at the end of this that will really expand on the documentation compliance part of this. And so we'll see what happens there. But anyway, so we kind of ended with the documentation compliance component. Now what we're going to get into is coding and billing. We also talked about, last time we talked about provider enrollment and then the different options that you had as far as being a PAR provider versus a non-PAR provider, the opt-out rules for Medicare for chiropractors and so on. But moving forward now, we're going to talk today about coding and billing, both on the Medicare Part B, original Medicare, and the Medicare Advantage side. We're going to talk about profiling your Medicare patients correctly so that you're sending out claims correctly. We're going to talk about what needs to be on your claims in order for a claim to go through and what shouldn't be on your claims. We're going to talk about the ABN forms. We're going to talk about audits. And again, if we have any time toward the end, we will really expound more on the documentation compliance portion of Medicare. So let's go ahead and get started. Before we move forward, I do want to throw out some definitions that you're going to be hearing. You're going to be hearing me talk about CPT codes and ICD codes, HCPC codes, and modifiers in this section. And you may be very, very new at this, so you may not know what this means. If you do, it's just a review. CPT stands for Current Procedural Terminology, and CPT codes represent medical, diagnostic, and laboratory procedures. And basically, here's the deal. When you send a claim in to the insurance company, you're not sending a long-handed description of what you did. Everything you send in is in code. So essentially, this is like the language of medicine. And every definitive procedure has assigned to it a CPT code or a HCPC code. Now, CPT stands again for current procedural terminology. The HCPC code, HCPC stands for Healthcare Common Procedure Coding System. And this represents supplies, DME, injectables, grafts, and so on. In our world, in the chiropractic world, we don't use HCPC codes that much. There is one in particular that you would use fairly commonly, and we'll get to it when we get to the therapy coding section of this presentation. But most of the time, you're going to be working out of the CPT code book. Now, the CPT code book is published and maintained by the American Medical Association. It's published annually, so it comes out every January. There's a new CPT code book. There are over 40,000 codes in the book that represent different procedures, diagnostics like X-rays, MRIs, laboratory tests, lab procedures, and so on and so forth. In chiropractic, we probably use 25 of the 40,000 codes on a routine basis, maybe 25. For some of you, you may use, 5 to 10 of the CPT codes. So do you need a CPT code book? Probably not. But but if you are, let's say you're listening to this and you're a medically integrated practice, you'd be using more CPT codes than straight chiropractors would be using. ICD-10 represents the International Classification of Diseases, the 10th edition. Sorry about I spelled international wrong, internation. I forgot the AL, but it's the International Classification of Diseases, the 10th edition. And these represent your diagnosis codes. So the CPT codes represent the what did you do today? What procedures did you do? The ICD-10 codes represent the why. Why did you perform this procedure? Okay. And in order to file an insurance claim, you have to identify both. You have to identify the what, and you have to identify the why, as to why you perform these procedures, because all procedures that are payable by an insurance company are based on something called medical necessity. You have to prove that the procedure that you did was medically necessary by the diagnosis that is represented on the claim form. Okay. And this isn't just for Medicare, this is for all insurance claims, whether it's a PI claim or a commercial policy, a work comp claim. You have to use both CPT codes and ICD-10 codes as representing what you did and why you did it. Now, your HCPC codes are published and maintained by CMS, the Center for Medicare and Medicaid Services. So there's this rule that I want you to kind of keep in your mind in that occasionally both CPT and HCPC have the same codes, the same definition of codes. And I'll show you one here in just a little bit, but they have the same definition of codes. And so the rule is that if there is a similar code in both CPT and HCPC, if it's a Medicare patient, you would use the Medicare code. If it is a commercial patient, you would generally use the CPT code, unless the commercial plan adopts the Medicare code. Same thing with Medicaid. So if it's a Medicaid, and I know we don't do much billing in Medicaid here in Texas, so, but if it is a Medicaid patient, then if there's a parallel code, the rule is that if it's Medicare, Medicaid, or a federal program, you're going to use the HCPC code versus the CPT code. The last definition that I want to talk to you about are modifiers. Now, modifiers are appended to CPT codes or HCPC codes, and they give additional clarity and definition to your procedure. I call these the, and by the way, we performed this procedure, but we performed it only on the left side of the body, or we performed it bilaterally, or we performed this procedure as part of a physical therapy plan of care, or we performed this procedure, but we have an ABN on file and we know that you probably aren't going to pay for it. So those are the modifiers that are appended to the CPT code that give the additional information to the insurance company to make a more robust claim. Okay, so these are the different codes that we're going to be looking at today. So the first thing I want to talk to you about are the CPT codes that are payable under the Medicare program. You have basically three of them. Now you have chiropractic manipulation codes in general are 4 codes, and those are your 98940, and your CPT codes, by the way, are usually 5 numerical digits. Occasionally, you may have a 4-digit code that ends in a letter, okay? So like, for example, for those of you that do Shockwave, right? I believe Shockwave is 0101T. That is the CPT code for shockwave therapy. And now it's not payable because it's not a primary category CPT code, but most of you're going to identify that the codes coming out of the CPT code book, which is the AMA book, because they are usually 5 numerical digits. Your HCPC codes are always a letter. It starts with a letter and then ends with 4 digits. They're still 5-digit codes, but they always start with a letter. So you can usually guess at a HCPC code because it will start with a letter, where the like your S8990 chiropractic manipulation or spinal manipulation for maintenance actually comes out of the HCPC code book, or S9090 spinal decompression therapy comes out of the HCPC code book. So your chiropractic manipulation codes are 98941, 40, 41, and 42. These represent spinal manipulation based on the number of regions that you're manipulating in which you have a medically necessary condition. So listen carefully about that, because oftentimes chiropractors will get this wrong and they will base their manipulation code based on the segments manipulated versus what you can document in your note as medically necessary. So let's say you're listening to this and you're an activator practitioner. If you're an activator practitioner, you're going to, put your activator on pretty much every segment of the spine, right? And so typically an activator practitioner adjusts full spine. Many of us diversified practitioners will adjust full spine. You'll do your cervical, thoracic, and lumbar adjustments, and you may even put in a sacral block. So you're adjusting your 5 regions. That doesn't mean you can bill a 5-region manipulation. You have to have a condition that would be deemed medically necessary in all 5 of those regions in order for you to bill a 98942. So please make sure you understand that. And guys, again, if you have any questions about this, feel free to type it into the Q&A. You can also type it into the chat box if you're more comfortable doing that. We'll look at both of them when we get to our stopping points for questions. But And then you have 98943, which is an extra spinal manipulation. And this is a manipulation for regions other than the spine. So this would be if you're manipulating feet, hands, elbows, shoulders, toes, knees, that would be a 98943. Now, please understand that that code is not covered by Medicare, okay? That is not a Medicare covered code, at least Medicare Part B. We are going to talk about extended benefits under Medicare Advantage, and in some cases, it may be covered under Medicare Advantage plans, but never under Medicare Part B, your original Medicare. Your 5 spinal regions for the 98940 1 and 2 codes are your cervical, thoracic, lumbar, sacral, and pelvic. Those are the classified spinal regions for the assignment of the spinal manipulation code. Now, those are the only 3 codes that are covered by Medicare Part B. We're going to be looking at some other codes today because some of these codes actually may be covered under your Medicare Advantage plans, and of course, they would be covered under most of your commercial plans, okay? But since we have to deal with both Medicare Advantage and Medicare, it's important to understand some of the other common codes that you would be using and possibly billing for in your with your Medicare population. Okay. You're not required, all of these codes that we're going to be looking at now, you are not required to bill any of these codes to original Medicare, but you may need to under certain conditions, and we'll talk about what those conditions are here in just a few minutes. Some of the Medicare Advantage plans will cover these codes, and there are some what we call true secondary plans that may cover these codes. So even though Medicare B doesn't cover them, sometimes a patient has a secondary plan, like a retirement policy from their employer that has really, really good benefits, and they actually cover those codes. So you have to know how to bill these non-covered codes in order to get a proper denial from Medicare so that you can then turn around and bill the secondary for payment. So some of these true secondary plans, and I'm just going to say for Medicare Part B, that's going to be maybe 5%. So again, it's not that much, but you could see, as much as 40 or 50% of your Medicare Advantage plans will actually cover these codes. And as we ascertained last week, we're looking at now in the state of Texas, about 55% of the population in Texas has a Medicare Advantage plan versus Medicare Part B. So it is likely that you're going to encounter times when these codes are actually covered by your Medicare patients. So the first ones that I want to look at are your exam codes. These are your evaluation and management codes. They are codes 99202 through 99205, and then 99211 through 99215. You'll notice that the difference in these codes is in the 4th digit. The 4th digit is for new patients is a 0. The 4th digit for established patients is a 1. And the rule is a patient is considered a new patient if they have not ever been seen by you, or if they have been seen by you but have been inactive for more than 3 years. So once 3 years, if you have a reactivation, a patient that reactivates after 3-4 years, you are going to do an exam on that patient and code it as a new patient exam. Okay, this is the code. These are the codes that you use for your part exam. So we talked about how to justify medical necessity of a subluxation last week, and we said there were 2 ways to do it, right? One is through X-ray, where you have to take an X-ray that is been proximate to the initial date of treatment, which is 12 months prior or 3 months after the initial treatment date, or through your part exam. And the part exam is typically the way that most chiropractors will justify medical necessity on a Medicare patient. Now, your E&M stands for Evaluation and Management. We'll just call them exam codes. And the exam codes for established patients are your 211 through 215. Now, I'm just going to tell you, for most of you, I would never use a 211 code. And the reason why is that from a documentation standpoint, a 211 is actually classified as a nurse's code and not a physician code. The big difference is that this is the code that in medicine, on the medical side of things, is typically used for a follow-up visit where a patient comes to have their levels checked for blood thinners. Okay, they go in and they have like a Coumadin clinic where a bunch of patients that are on different blood thinners are going to come in and they're going to have an evaluation by the nurse. The physician won't even see them. And one of the big differences in the element of documentation is that a review of systems and an exam is really not done in a 99211 code. Okay, so when you look at the criteria for E&M, the physician code starts at 212. Okay, so that should be the lowest level of exam code that you ever use in your practice. If you're using a 211, it's really not a valid code for you, and it's not good for chiropractors to use a 211 because you're classified as physicians. And if you want to stay classified that way and you keep billing 211s out, then this is where you've got entities like the Texas Medical Association and the physical therapists that are saying you shouldn't be classified as a doctor. Okay, and you are under Medicare standards. So please make sure you're not using a 211 code. Also, this code can be done or can be billed when you are doing other procedures if the correct climate applies. And we're going to talk about this bundling of the E&M codes with other procedures. And I know that many of you struggle, even on the commercial side of things, with billing for a re-exam, for example, when you do a spinal manipulation on the same visit. And we'll talk about that a little bit here in just a few minutes. But these essentially are your codes. Now, the choice of code, whether you bill a 99202 or a 99203 or a 99204, would be based on one of two criteria, what would they call a key element of the evaluation and management code. All right. And that key element is going to be either time, how much time you spent face-to-face with the patient, or medical decision making. And there's an algorithm that you can use if you're going to use medical decision making as your key element for an E&M service. And it's going to be based on the number of diagnoses that you are evaluating or assessing, comorbidities. Does the patient have significant comorbidities contributing to their diagnosis? It could involve review of previous medical records, review of previous imaging. Every time you add an element, you're adding an element of more complex medical decision making that allows you to bill a higher level of code. Many chiropractors use the straight up time, and so there are different time elements based on each code in how much time you spend with the patient. But you have to be careful about this because it's not the amount of time that they spend filling out paperwork. So it's not like the total time in the office. It's the total face-to-face and non-face-to-face provider engagement. All right, nothing to do with engagement, and it also does not include the treatment. So if you're treating a patient and you're billing it under the E&M service, it doesn't include that. So be aware of the kind of the rules for evaluation and management codes. All right. The next set of codes that I want to look at with you are the spinal X-ray codes. And these are the 72,000 series codes. Probably your most common X-ray codes are going to be the cervical X-ray, 2 to 3 views, thoracic and lumbar X-ray, 2 views or 2 to 3 views. That's your 72040, 72070, and 72100. And there are X-ray codes for a full spine series, which is your 72082. Now, technically, if you are taking 3 sets of X-rays using 3 different films, okay, whether it's digital or hard film, technically you should be able to bill the 72040, 70, and 100, okay? And I say technically because some payers, due to the fact that there is this comprehensive full spine series code, will not allow you to unbundle those 3 X-rays. Some payers actually allow you to do it. Now, the main thing is coming back to the 40, 70, and 100, if you are billing them separately. So let's say you take a full spine series and it consists of one set of 2 to 3 view cervicals, one set of 2 view thoracics, and one set of the lumbosacral, low back and sacrum, 2 to 3 views. And usually it's A to P and lateral, okay? A to P, anterior to posterior, and then lateral, side to side. You would want to make sure that on the claim itself, you're pointing the diagnosis code that applies to that X-ray as the primary diagnosis code. And again, this is for if your Medicare Advantage claims cover X-ray. This is also applicable to your commercial claims as well. You have to remember that most practice management and billing software programs will default to the first 4 X-rays on your problem list, or I'm sorry, not the first 4 X-rays, the first 4 diagnosis codes on your problem list. And so every single code that you bill typically defaults to A, B, C, D on the claim form. And I'm going to show you a visual of the claim form here in just a little bit. But A could be, for example, representing a lumbar subluxation, and B could be a cervical subluxation, and C could be a thoracic subluxation code. And because of that, if you bill the cervical X-ray, but the lumbar subluxation is the primary, that's what's going to be read when the claim is being processed. And the insurance company is going to say, no, 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 we're not going to pay for this because you are telling me that you're billing a cervical X-ray for a lumbar condition. So this is where something called diagnosis code pointing becomes very important. You or your biller has to review these codes and make sure that the correct primary diagnosis is assigned to that procedure, okay? And we're going to use diagnosis code pointing terminology a lot in this next segment. So be aware of that your software typically is just going to default to the first 4 diagnosis codes on the list. Same thing with extraspinal manipulation. Usually, when you create your problem list of diagnosis codes, you have your cervical diagnoses, your thoracic, your lumbar diagnoses, and then somewhere at the bottom, you have shoulder pain, or you have wrist pain, or you have, arthritis of the knees or something like that, right? That's way down the list. But then when you're billing the extra spinal adjustment, it's defaulting to cervical, thoracic, and lumbar. And because those are your first four diagnosis codes. Well, again, you have a code, a CPT to diagnosis code mismatch. And as such, what is happening is that mismatch is going to be picked up on the claims processing side of the insurance company. And the insurance company is saying, well, we're not paying for an extra spinal adjustment for a cervical problem because you didn't point the extra spinal diagnosis to the extra spinal procedure. So keep that in mind when you're doing your billing. This is a lot of times I'll have doctors come to me and say, well, I never get paid for the extra spinal adjustments anyway, so I leave them off my claims. And it's like, really? You don't get paid? Why? And then when we look at their claims, it's because they're not pointing the correct diagnosis code to that extra spinal adjustment. So I digress, but kind of moving back to the spinal x-ray codes, some payers will only allow the 72082 if you bill or if you take a full spine series. They're going to tell you that you're going to have to bill the 72082 code for the full spine. All right, are there any questions on x-rays and billing for x-rays? Just going to open the chat box real quick.
Hi, Lisa. We did get a couple requests for handouts.
I put the handouts up here. I can do it again.
Yeah, maybe just do it again one more time so that
Let me,
anyone that came on late can see them.
yeah, okay. Okay, it's uploading right now. There was a question about a black and white version of the notes, probably because this file is so big, it's 22 megabytes. I can get them. What I'll do is I'll create a black and white version on the next, we're going to do a 15-minute break about halfway through the session today. And when we do, I'll go ahead and do a black and white version for you all as well. Okay. All right. So looking at these, if we don't have any questions about x-rays and exams, and again, remember, Medicare Part B isn't going to pay for them, but you still have to have, oh, we have a hand raised. So William, do you want to come off of mute and ask your question? Are they allowed to, Maggie?
I think
Come
I
off.
just unmuted William.
William, did you have a question? Dr. Hampton? I'm going to ask to unmute. He's still muted. Oh, here he
No,
is.
that was an accident.
Okay. Oh, it was an accident. Okay, no problem.
Sorry about that.
Just want to make sure. Any of you are, if any of you do have a question, okay, and you just don't want to type it and you just want to ask it, do what William did. There is a place in your Zoom menu where you can raise your hand. So if you raise your hand, I may not address it right away if I'm in the middle of a thought, but when we get to that stopping point, I'll address the hand raises, and then you can come off of mute and ask your questions. So please feel free to use the hand raise as necessary. Okay, guys? All right, perfect. So let's move on to some common therapy codes that many of you use in your day-to-day treatment of patients. And again, these are codes that are not covered under original Medicare, but they are covered under or may be covered under your Medicare Advantage plans. And they usually are covered under your commercial plans like Blue Cross of Texas covers these, Aetna, Cigna, Humana, et cetera, okay? So your therapy codes are broken down into different levels of modalities and therapeutic activities. And you have what are called supervised modalities, modalities under constant attendance, and then skilled therapy procedures. Typically, your modalities under supervision and under constant attendance are your 970 codes. The skilled therapy or the skilled therapist procedures or the skilled procedures are 971 codes. So on this slide, what we're looking at are the first set of modalities that are supervised are your mechanical traction codes, E-stim, and notice it says use G0283 for Medicare and Optum health plans, UHC health plans. So remember at the beginning of our session, I talked about the code book having parallel codes. This is one of them. So the AMA code book has 97014 as a description for unattended E-stim. Okay, this is the one where you've got an E-stim unit, you use the electrical pads and you place them on the patient, you know, wherever the issue is that you're wanting to treat. You turn on the E-stim unit to whatever level they're comfortable, and the CA or the therapist walks away. This is called a supervised modality. It does not require constant attendance. There is a parallel Medicare code called E-stim for indications other than wound care, okay, G0283. And for Medicare patients, let's say you have to bill E-stim to a Medicare Advantage plan, okay, and I will tell you that United Healthcare has also adopted this rule. So any United Healthcare plan, it could be, if it's United Healthcare, it could be UMR, which is a United Healthcare product. It could be AARP. It could be Golden Globe. All of these are United Healthcare products. They will not pay for E-stim. So if you get a denial back, you bill E-stim to United Healthcare, it's going to be denied, and it's going to say this is not a valid code. If you turn around and rebill it with G0283, you'll get paid, all right? So same thing with Medicare. Medicare and Medicare Advantage will not recognize 97014. You have to use the G0283 if you're billing Medicare Advantage plans for unattended E-stim, okay? All of these codes, vasopneumatic device, infrared therapy, traction, these are all unattended but supervised modalities, meaning there's somebody in the room that is monitoring the patient, but they're not with the patient constantly, okay? Now you also have the E-stim code under constant attendance, 97032. And I do find that this is sometimes incorrectly used. And what happens is we'll see this quite frequently where a provider, let's say we take over their billing, where, you know, the provider says, Lisa, we want Gold Star to do our billing for us. And we start looking at their coding, and we see that they're using 97032 and never using 97014. So what we do is we question the provider and say, tell us about how you do E-stim. So they'll tell us, you know, basically that what they're doing is unattended E-stim and not attended under constant attendance. And we'll ask them, well, why are you billing the 97032 instead of 97014? And they'll say, because it pays more. But that's not a good enough reason. You have to fulfill the requirement for E-stim under constant attendance. So this is what E-stim where the CA or the rehab tech is going to place the pads, and they're going to turn up the electrical current and have the electrical current for that electrical current going maybe for 30 seconds to a minute, and then they're going to turn it up some more and have it going, and then they'll keep turning it up until the patient has reached a threshold that they can't, handle it anymore. And then they'll start turning it down and they'll modulate it like every minute or so. So it's under constant attendance. The CA is constantly changing the electrical current and the modulation of the electrical current. And if you're not doing that, you shouldn't be billing 97032. The other difference is that under these constant attendance modalities, these are billed based on time spent with the patient under constant attendance, okay? And the other modalities, the supervised modalities, are based on a unit. So it doesn't matter how much time they have e-stim or how many places you apply the e-stim. So you could do e-stim on neck and shoulders and then reapply the pads to the lower back. You can still only bill for 1 unit of e-stim regardless if it is unattended. So this is just something to keep in mind, that the constant attendance modalities, now these do not require skilled therapists to perform, but it can be done by a rehab tech or a medical assistant, or just a CA can be doing the constant attendance modalities, as long as they are under the supervision of a provider. So, you providers, just make sure, like, this was way, way back in the day before the rules were clearly defined. But I remember, 25 years ago when I was working as a CA, sometimes the doctors that I worked for would go on vacation. But we would have patients come in to do their therapy and their rehab while they were on vacation. You can't do that. You have to be there. All right. So you can't have therapy days where you are not in there unless you have a physical therapist that is actually working for you, and the physical therapist is supervising physical therapy assistants. Then there are some different rules that if that's the case, and you do have a medically integrated practice with physical therapists and physical therapy assistants, and you would like more information on supervision requirements, please feel free to reach out to me, and we can schedule a complimentary consult on that. So these are your modalities: supervised and constant attendance. All right. Remember that supervised modalities do not require direct one-on-one patient contact, and constant attendance modalities do require direct one-on-one, continual, constant, right? That's the definition of constant, is continual patient contact, all right? And these are your common codes for both supervised and constant attendance modalities. Then you have this group of therapeutic procedures, and we refer to these in chiropractic as our rehab codes, where we are doing therapeutic exercises with patients to help them develop strength, endurance, and improve range of motion, neuromuscular reeducation to help patients improve coordination, balance, posture, and kinesthetic sense. You have massage therapy, which is the technique of stroking, tapping, kneading, compression, percussion. This is to help patients with overall pain, reduce overall pain and muscle spasm. Now, it's not covered by all payers, and always verify if that code, if you have a massage therapist on staff. Now, the massage therapy codes also with some payers can be performed by a massage therapist. And in some cases, like for example, with the VA, if you have a massage therapist and you're treating VA patients, your massage therapist has to be credentialed with the VA, and you have to bill it under the massage therapist as the rendering provider. You can't bill it under your NPI as the rendering if the massage therapist is performing it, if it's a VA patient. So this is a payer-guided code in which you have to check to see if the code is even covered under the patient's plan. If not, then it's just a cash service, okay? Now we have another code, which is 97140, manual therapy technique. This is kind of a multifaceted code. The description of this code is manual therapy technique, including manual, not mechanical, traction, manual lymphatic drainage, and joint mobilization, okay? It is a very problematic code for chiropractic, okay? And there's a reason for it. It is often one of the most incorrectly and improperly coded procedures in the chiropractic field. It is one of those codes that can get chiropractors into a lot of trouble with post-payment audits and recoupments. So one of the things that happens is that some DCs will erroneously use this code instead of 97124 when massage is not covered under a patient's plan, or because you don't understand the difference between the different types of massage that this represents. So a massage therapist under their scope in the state of Texas can perform a manual therapy technique, which is typically the myofascial release, and in some cases, mechanical traction, where they're stretching out the spine as part of their massage procedure, okay? Typically, chiropractors are the ones doing the joint mobilization. That is, and that's where sometimes there's a problem when you're billing 97140 and your spinal manipulation codes at the same time, is because 97140 in the description in the CPT code book includes joint mobilization, as does spinal manipulation. So spinal manipulation also includes the description of joint mobilization. And so what happens is that if you're billing these two codes, essentially you're telling the insurance company that you're doing joint mobilization twice. And so the insurance company says, well, we're not going to pay for it twice. And so you can bill it at the same time, the 97140 and the 989 code, the spinal manipulation code, but you have to prove a distinct procedural service. So you have to prove that it was either performed by a different provider, like your massage therapist, and there are modifiers that allow you to do that. But remember, if you have a massage therapist doing it, you typically have to bill it under the massage therapist's NPI. And sometimes it's not covered. If it's 97124, it may not be covered. So there are some very specific billing rules that you have to follow in order to be able to bill the 97140. Don't use this code in place of 97124 just because 97124 is not covered under the patient's plan, okay? It's kind of like that eSTEM code where 97032 pays more, so you use that code. No, you can't do that. Same thing with 97140. Don't have your massage therapists always billing 97140 because that would not be appropriate. Typically, this is reserved for myofascial release, deep tissue massages, more like sports type massages, and where the massage therapist is getting in real deep to move the toxins out of the lymph nodes and things like that. So just make sure, and you have to document this very, very well so that or your massage therapist does, so that the insurance company can understand exactly what was done as part of the manual therapy technique. Now, these codes are timed codes, and so each of these codes is by 15-minute segment, and we're going to talk about like what Medicare calls the 8-minute rule. So you have to perform at least 8 minutes of each of these types of codes: the therapeutic exercise, the neuromuscular reeducation, massage, the manual therapy. All of these are each 15-minute codes, and it is required that these codes be performed by a skilled therapist, okay? So for Medicare purposes, a CA is not considered a skilled therapist, all right? The only types of providers that are considered to be skilled therapists are individuals with an NPI number. Okay, so that can be you, it can be a massage therapist that has an NPI number that is credentialed with the respective payer. It could be a physical therapist or a physical therapy assistant. Those are really the providers that have an NPI number that could bill for these one-on-one skilled therapy codes, okay? Some other procedures that you might be dealing with in your practice are 97150. This is for group rehab. So let's say, for example, you have a rehab area, like very many physical therapy clinics do. They have a big open area and they have different stations within the area. And you may have one patient on a treadmill, and you may have a patient doing wall band exercises using TheraBands. Then you may have a patient on a physical therapy table, and you have your therapist or your PT or your PTA is stretching them out. That PT that is stretching out the patient is one-on-one. The other two patients that are doing their exercises on their own and doing the treadmill on their own are in group therapeutic setting, right? Because they are not one-on-one. So you can bill a 97150 for the patients when they are in that non-one-on-one setting, right? And 97110. So let's say that same patient that's on the treadmill then goes to see the therapist one-on-one. At that time, you can bill for the amount of time, the 8 minutes or 10 minutes that the patient is with the therapist, either being stretched out or the therapist is with them, assisting them with their exercises, is standing right in front of them and monitoring them and watching them. But if the therapist has their back turned, if they're somewhere else in the room and they are not monitoring that patient, then you're going to, in that case, you're going to bill two codes. You're going to bill the group for the times that the patient is not one-on-one with the therapist, and that is not a timed code. It's 1 unit for that session. And then on top of that, you would bill the 97110 for however much time the patient has spent one-on-one with your therapist, okay? And then you have the 97530, which are therapeutic activities for functional performance. So there is also a misuse of this code. And sometimes it's hard to distinguish whether you should be using 97110, which is, if we go back to the therapeutic exercise code, that is to help patient develop strength, endurance, and improve range of motion. The 97530 code is used to improve functional performance. So this is typically used like in work comp claims when you're trying to get a patient back to where, let's say prior to being injured, they were required to lift 50-pound bags of dog food because they work in a warehouse, right? In a pet warehouse. And now they injured their low back. They can no longer lift that 50-pound bag of dog food. So you take them in and you do rehab exercises with them, like lifting exercises, lifting and twisting exercises that help them to improve their functional performance. In that case, you're going to bill 97530. So you have to identify which functional activity you are working with the patient on restoring in order to bill the 97530. Okay, 97110 incorporates general stretching, resistance bands, your gym balls, your stationary bikes, and that type of thing. So make sure you're applying the 97530 and the 97110 correctly. All right. So that's sort of a nutshell of the different types of the commonly used codes in the chiropractic space for Medicare and Medicare Advantage patients. It looks like we may have some questions in the chat box.
Hi, Lisa. Yeah, we did have a question early on. Dr. Sarver said, are you saying that if you're billing for all four spinal adjustment regions, CMTs, a 98942, do you have to make four pointings to validate an X-ray in each spinal area?
Only if you're using X-ray to justify medical necessity. So if you can do it by exam, right? So the patient could have, for example, they could have muscle spasm in the cervical area, and between the upper shoulder blades. They could have spinal degeneration in the lumbar, between L5 and S1. They could have some lumbar, degeneration. They could have disc narrowing in the thoracic area. All of those would have to be documented, and then that would allow medical necessity to be justified for adjusting all five segments of the spine. Okay, so remember, 98942 is all five. 98941 is 3 to 4. Okay, so you would not make four pointings in the um in the box 24, and I'll show that to you here in a few minutes when we go into the billing side of things. But you would essentially make sure that all of the five regions and the conditions are represented in box 21, and then box 24 represents the primary diagnosis. So like, where does the patient have the most significant issue? All right. And so this is where you would point the diagnosis code for the most significant area of subluxation. So if the majority of the subluxations are in the lumbar area, then M99.03 is your primary diagnosis for the 98941. But you would also have M99.01 and 02 listed as associated diagnoses. And then if you were ever audited, you would have to prove that there were conditions that would justify medical necessity for you assigning a subluxation to those different areas. I hope that makes sense. Let's see.
That was the only question I've seen in the chat, other than just a request for the handouts, maybe in a smaller file format or in black and white.
Yes, I'll be happy to do that. All right, let's take a look now at the Medicare ICD-10 codes. So remember, we just talked about, actually what I'm going to do is, we usually take a little break on the hour, so we're going to go ahead and do that. I'm going to take a 5-minute break. It is 9:35, so we're going to come back here at 9:40, and then we'll move into the Medicare ICD-10 codes. And while we're there, I'm going to stop sharing my screen so I can reprint those handouts in black and white, okay? Let's see. All right, just one more minute and then we're going to get started again. I did upload those handouts in black and white. It's 9:38 a.m. is when I did that. So hopefully you'll be able to maybe see them better and not use as much ink when you're printing them. All right, we are back at our time. So before the break, we talked about the CPT codes that are commonly used in the chiropractic setting. And
Oh,
we
sorry, one real quick before you start.
Sure.
Now that we've returned from the break, can everyone please put their full name and license number in the chat? Thanks all. Okay, Lisa, go ahead.
Yeah. So for those of you, yeah. Anyway, we talked about the CPT codes and we talked about the common ones that are used in the Medicare and Medicare, Medicare B and Medicare Advantage space. And that is the half of the story of the what. What did we do? And those are the codes that would be placed on the CMS 1500 claim form in order to send it over to Medicare or your Medicare Advantage payers for reimbursement. The why are your Medicare ICD-10 codes. And these codes, again, for Medicare Part B are very, very limited. Novitas Solutions, which is your Medicare administrative contractor in the state of Texas, follows the coding and billing LCA A58345. Now, interestingly enough, this LCA was actually retired in November, but they are still referencing it as the go-to article for appropriating the correct diagnosis codes, primary diagnosis codes for your claims. So these are the diagnosis codes that support medical necessity and provide coverage for CPT codes 98940, 41, and 42. So you have, and they all start with M99, Mike 99.00 through 05, and then Mike 99.10 through 15, okay? And I will tell you, it is not frequent that under the chiropractic space, we see the chiropractors using the M99.10 through 15 codes, the subluxation complex codes. Typically, I see them using the 99.00 through 05 codes. And you'll notice that each one of these represents a different region of the spine. So when you're billing, let's say a 98941, you would have to have on your claim form at least 3 of these M99 codes, with one of them being assigned in the primary position, in the first position. And when I show you the CMS 1500 claim form, I'll show you where these codes are placed and how they're pointed in order to assign the primary diagnosis from your problem list, okay? So for those of you who do have a question about what is the difference between the somatic dysfunction and the subluxation complex, this comes from Gonstead, and there is some criteria. Basically, it states that the subluxation complex is identified by a loss of normal position, irritation to delicate nerve tissue, muscles that are either tight and spasmed or weak and atrophied, localized inflammation and heat, and then degeneration over time, causing other organs and systems of the body to lose their proper function. So basically, this is where subluxation is taken to address associated comorbidities as a result of the subluxation itself. Now, many of you have learned, over the years to assign secondary diagnosis codes to your subluxation codes to define whether you're dealing with a short-term treatment of a patient, a moderate-term treatment of a patient, or long-term treatment of a patient. And remember, we defined it last week that Medicare does not assign visit limitations, okay? What they do say is that certain conditions may require very little treatment, whereas other acute conditions may require more treatment, up to 3 months on the acute subluxation side of things. And then on the chronic subluxation, it states that certain conditions may never go away, right? As is the case, let's say, with spinal degeneration, may never go away, but where ongoing treatment results in improvement in the patient's function, in their ADLs, their activities of daily living. And so it's those secondary diagnosis codes that define where your patient lands. Are they landing in a very short-term plan of care, a moderate-term plan of care, or a long-term plan of care? And this is where these diagnosis codes help you if you get a denial for medical necessity, if you have notes that and documentation that proves that you're treating a chronic condition in which the treatment that you're rendering results in improvement in function, and the secondary diagnosis code supports that, like spinal degeneration, then you can continue to treat a patient under active care, right, as a chronic patient. These are some of the examples of secondary diagnosis codes in the short-term treatment category. So and most of these are your pain codes and your muscle spasm codes. So this is the P and T portion of the part exam, the pain and then the tissue changes, right? So your muscle spasms, your pain, because as a chiropractor, I've listened to enough reports of findings over the years to know that what many chiropractors will say to a patient in a report of findings is pain is the last thing to show up and the first thing to leave when you have spinal problems, okay? So typically, the work that you do in adjusting patients will help them get out of pain fairly quickly. But then many of you take it to continue to restore proper movement of the joints and the vertebra So it's not just about reducing pain and treating muscle spasm. If that is all you do, then these would be your secondary codes, and these would result in a short-term treatment plan of an acute patient. Medicare has defined under short-term treatment under the LCAs that publish these. Now, the Novitas LCA does not publish these diagnosis codes, okay? There are some other MACs throughout the US that publish these diagnosis codes, okay? And you can use those as a guide, all right? And you can use them as a way to appeal medical necessity if you have that LCA. But you know, you're just going to have to understand that if these diagnosis codes are present on your claim and you don't have any other diagnosis codes that support a longer term of treatment, then Medicare will, through their data mining operations on their side of things, will see only subluxation and pain codes, and they may have automated medical necessity denials at 12 visits, where you just start getting either outright denied, or you may start getting records requests to see, why are you treating a patient beyond 12 visits if the only diagnosis codes on your claim are subluxation and pain codes? Because how long does it take to get a patient out of pain is what the rationale is, right? If it takes more than 12 visits and the patient still has significant pain, something else is probably going on that warrants further investigation. Then you have your secondary treatment codes in the moderate term treatment category. And these are usually your 12 to 18 to 20 visits. And these are typically the codes in which the subluxation is involving nerves. And as such, you're having radicular symptoms, such as radiculopathy in the cervical region, the thoracic or the lumbar region, where there's radicular pain moving throughout the body, okay? So like a patient that has sciatica, you know, may have some type of radiculopathy going on as well, all the way down into the feet. Then you have your secondary DX codes in the long-term treatment category, which warrant, again, under the LCAs that publish these, say usually up to 30 visits, okay? And these are your disc degeneration codes. And this is where, if you're treating chronic patients, these are the types of DX codes that you would commonly see on your claims. These patients have degeneration in the spine that's never going to go away. This degeneration causes from time to time functional deficits or functional limitations. And so these would be the types of codes that you would look at. Now, this is by no means all the codes on the list. If you would like a full set of these diagnosis codes that represent short-term, moderate term, and long-term treatment, I would recommend purchasing the ICD-10 coding of the top 100 conditions for the chiropractic office by Dr. Mario Fucinari. He is a Medicare compliance guru. He was the chiropractor of the year in Illinois for several times running during his career. He's retired now and does mainly compliance work and instruction work. Some of you may have heard him speak in the past. He does a lot of webinars, and he comes out to conferences and teaches on behalf of foot levelers and CMIC. He has been a great colleague of mine, and he has this full list of these short-term, moderate-term, and long-term treatment codes in this book. This is a great book for chiropractors, because I don't know if, I can show you at some point what an ICD-10 code book looks like. It's got 75,000 codes in it. And maybe we use, 70 of those 75,000 codes. So really and truly, it's like 1/100th of a percent of the codes that are in that code book that are being used by chiropractors. But this really breaks it down to the most common codes that are used in the chiropractic settings. And so this is a highly recommended book for you as a resource to help you and your billers identify those codes based on the different categories. And there's other great coding rules in there as well. All right, let's take a look at the modifiers now. By the way, before we do that, do we have any questions? Kiara, I'm not sure why you can't see the documents uploaded into the chat box. Is that happening to everybody else, or are other people able to see? Let me go back and make sure that I set it to everyone. Yeah, I set it to everyone, so.
I went ahead and emailed it to Dr. Martinez. If
Oh,
anyone else
perfect.
is having that problem, just let me know.
Perfect. Okay, great. Thank you. I don't see any other questions. I don't see any hands raised. Let me just double check that. Oh, okay, perfect. All right, let's move on to the modifiers then. So remember when we were talking about the modifiers, what we were talking about were and by the way, we're giving the insurance company additional information about those procedures that we are performing in our clinical settings. So the modifiers that apply to Medicare that would be reported with 98940, 98941, and 98942 would be or could be AT, which represents acute or active treatment. GA, so GA, if it's appended to a 98940, or 2, is appended when you have an ABN form on file and you know the patient is now a maintenance patient, but the patient still wants you to bill Medicare just in case. And so what you would do is you would bill Medicare with a GA modifier instead of an AT. Medicare would deny the claim and they would deny it to the patient responsibility. If you leave the modifier off, then Medicare would deny it, but it would be to a contractual obligation for you to write that off, okay? The GZ modifier would be used if you're billing a maintenance visit in which you have not gotten an ABN. And if you did not have an issue an ABN to the patient and they didn't sign one, you would bill it the 98940, or 2 code with a GZ modifier. Medicare will automatically deny that and make you write it off. Okay. So again, this is not a modifier that you want to use, but from a compliance standpoint, if you are billing a maintenance adjustment in which you have no ABN, then you're supposed to bill it with the GZ modifier, and then Medicare will not cover it. They'll just tell you that you have to write it off. A few other modifiers that you may use would be for your non-covered codes. So if the patient, let's say they have one of those true secondary plans where while Medicare B won't cover the exam, the secondary will. So in that case, you would bill the exam code, but you would want to append it with a GY modifier that tells Medicare that you understand that this is statutorily not covered by Medicare. Medicare will deny it. They'll deny it to patient responsibility. So you'll get a PR 50 which is on a code that is on the EOB that says patient responsibility, not medically necessary, or PR 96. PR, the 96 means a non-covered service. But because it's PR, the balance stays on the claim, and then it allows you to bill the secondary for reimbursement. Okay, so that is the modifier that you would use on all other codes that you would bill to Medicare Part B that you know are not covered, but that the patient is asking you to bill. And then again, you may have some patients that simply don't believe you. They don't believe Medicare is not going to cover this. And so you tell them, okay, well, we'll bill it. You bill it with the GY modifier. It comes back non-covered, patient responsible. The patient will get the EOB saying you are responsible for this cost. All right. And then you can bill them for those services, or if you collect up front, then you can support that collection. Okay. The GP modifier is used on your therapy codes. And again, this is typically in the Medicare Advantage realm, where you may be billing physical therapy codes for reimbursement. You have to make sure that you are appending the GP modifier. The GP modifier states that the patient is under a physical therapy plan of care. Now, a chiropractor can write a physical therapy plan of care. It's part of your treatment plan. So if you're going to use the GP modifier, please make sure that you actually do have a treatment plan that incorporates the physical therapy procedures, okay? Otherwise, you're lying because you haven't written a treatment plan in which the physical therapy procedures are included as part of your plan of care. You also have a modifier 59. Now, this is the distinct procedural service. So this is to be used when you're billing code pairs that are subject to what is known as NCCI, National Correct Coding Initiative, code pair edits. Medicare has a subset of their CMS.gov website called NCCI, National Correct Coding Initiative. And it is a database of codes, CPT codes, that when paired with other codes are assigned either an indicator of a 0 or a 1, okay? If these two code pairs are assigned with an indicator of a 0, it means that these two codes may never be billed together. Like if you ever build a 98940 and a 98941 on the same encounter, that code pair would be assigned an NCCI edit with an indicator of 0, saying you may not bill a 1 to 2 region manipulation and a 3 to 4 region manipulation on the same visit. Okay. And even if you do it different days or different times of the day, you still would not be able to bill those together. Okay. Because it's 2 spinal manipulations and you can only bill 1 a day. Now, 98940 and 97140 has a code pair indicator in NCCI that says 1, right? It's the indicator 1, and 1 means if you use an appropriate modifier to unbundle these two codes, then they can be paid and reimbursed separately. The modifier that you typically use when you are unbundling a code pair that is showing up in the NCCI database, pair-to-pair database, is 59. Also, Medicare has some modifiers called X modifiers, and the XS modifier is a separate structure. So essentially, well, let's say, for example, you do a 1 to 2 region manipulation on the low back. All right. You point your diagnosis code to the low back problem. Then you have your therapist or your massage therapist or yourself do some manual traction in the cervical area or maybe you're doing some deep tissue lymphatic drainage up and around the the upper traps, and that is a different anatomical region than the treatment of the 98940. So then what you could do is you can bill a 98940 and a 97140. You append the 59 modifier as a distinct procedural service, and you point the diagnosis code to the other anatomical region that you treated, okay, under the 97140. You do have to make sure your documentation supports that, all right? And then it can be paid separately. Now, I will tell you that many times insurance companies may initially deny it, even if you've coded it right. But if you send in your medical records, you can appeal it. And if you send in your medical records, then they'll turn around and they'll go ahead and pay for it because you will have met the criteria for unbundling that code. All right. Now, if it's a Medicare claim, you can use multiple modifiers. You can put up to 4 modifiers on a service line. There's room on the claim form itself for up to 4 modifiers. So let's say this was a Medicare claim, Medicare Part B, you would bill 98940 AT, right, for active treatment or acute treatment. And then your 97140 GY, statutorily non-covered. We know it's not covered. We're also performing it on a different region of the spine than the 98940, and we are doing it as the patient being under a physical therapy plan of care. So you're giving the insurance company all of the criteria for the use of that 97140 code using your modifiers. One of the rules for modifier use, and I get this question a lot, is what is the order of the modifiers? And the general rule for ordering modifiers is that any modifier that affects pricing is used first. Informational modifiers are last. Okay, so the GY modifier affects pricing for sure. The 59 modifier affects pricing, and the GP modifier is informational. The patient is under a physical therapy plan of care. So that is the order in which you would use the modifiers when you're billing. Okay. Any questions on DX coding? Okay, all of these have to do with sending out notes. All right. And please remember, folks, that this has been, I know some of you are wanting your staff to hear this, and I agree. I think, some of the stuff that we're talking about, especially today, is going to be very, very helpful for your billing staff. And so if they're not sitting in on this with you, this is recorded and will be recorded. So you can take the recording and you can, what I would do if it was me and I had my own clinic is I would find the different topics and possibly use it as a training tool during my staff meetings. And so I would take maybe 15 or 20 minutes of this, and then at one of your staff meetings, show it and give them the handouts for it. And then you can kind of discuss it and discuss your strategies. So remember that this is being recorded as well. So you'll have a copy of it. And by the way, Maggie, once the recording is done, if I can get a copy of it too, I would really appreciate that.
Of course.
All right. Do we have any questions, any hand raises on diagnosis coding? I think you guys just want to get out of here. Because I tell you what, when I'm teaching this live, I get a lot of questions about DX coding. And so, all right, we're going to go ahead and move on to billing and the proper billing procedures for both Medicare and Medicare Advantage. So the first thing I want to talk to you guys about is the CMS 1500 form. Now, we're going to be relaying information about the CMS 1500 form, which is a paper form, okay? For those of you who, if you can see it, this is an example of a CMS 1500 form. I think if you have me on camera, you can see the form itself. It is this is the government approved form. It is all in red ink. There is for the government approved form, there's a whole bunch of writing on the back, and I'm going to actually read some of this to you when we're going through the CMS 1500 form itself. The CMS 1500 form itself is represented by 33 data fields, and we call these data fields boxes. So when I refer to box 1, box 3, box 33, I'm referring to the data field on the CMS 1500 form itself. Now, most of you are going to be billing your claims electronically, so you're not going to be using the CMS 1500 form. However, when you're dealing with your clearinghouses, so that if there is an issue with a claim, for example, in the clearinghouse, you would refer to the boxes of the CMS 1500 form. In electronic claims, boxes are converted to something called loops and segments. And so, box 24E equals loop and segment 2400 dash something something. I don't remember all of them. There's a ton of them, right? But when we're talking about the claim form, rather than the loops and segments, and to give you a visual picture of what an insurance company is looking at when they are adjudicating a claim, we're going to actually use the visual picture of the health insurance claim form. So when you're billing a claim to Medicare, at the top of the claim, or as you're submitting the claim electronically, you're going to submit it to your Medicare administrative contractor. And depending on the clearinghouse that you're using, you'll be issued what's called a payer ID, and it's an electronic address, essentially. Okay. Now, some of you, that I get a question a lot is, can I bill my claims on paper? And the answer is yes, under certain criteria. There is a waiver that you can apply for to send your claims out on paper. If you have fewer than 10 employees, okay, you can get a waiver, what they call a small practice waiver under HIPAA. Now, even though you can do it, I'm just going to tell you I don't recommend it, because if you if you submit your claim forms on paper, Medicare has 30 days to adjudicate. If you submit your claim forms electronically, they are required by law to pay you in 14 business days. So it cuts your payment time in half, all right? The next thing about paper claims is they also conveniently get lost, all right? And so your staff is going to have a very, very difficult time monitoring whether the payer, they're going to have to call Medicare, let's say 5-10 days after they mail the claim forms, and say, did you receive these claim forms? Because you certainly want to make sure they're received and not conveniently lost. Okay. So I'm not going to recommend that you fill out paper claims anymore, because if you do it electronically, what that means is you're going to get paid faster. You'll be able to monitor and track these claims much faster than if you do it on paper. Okay. Now, the way that CMS 1500 form is broken down is in these boxes. So you have essentially 33 boxes. The first 13 boxes represent the patient, okay? This tells the insurance company who the patient is, what their Medicare number is, whether the patient has any other insurance, okay? And it also contains the patient's instructions and directions. So box 12, okay, is the patient's authorization for release of records, okay? And so anytime you have a records request from the insurance company or from one of their contracted auditing representatives, it is legitimate to submit those records to them. I get a question about this a lot where the provider says, well, I'm being audited by Evicor or whatever, Covitv, or whatever the contracted auditing entity is, but they didn't send me a medical records release. Do I have to release the records? And the answer is yes, because on the claim form, the patient has a signature on file that says, I authorize the release of any medical records. It's built right into the claim itself. Okay, so if a claim is being audited for treatment, payment, and operations, the patient does not have to do a separate authorization with this auditing entity that is contracted by Medicare. Okay. Number 13, box 13, is the authorization of direct payment of the claim to you. This is known as the assignment of benefits. And so if you are a par provider with Medicare, the patient would have a signature on file that authorizes payment of benefits to the undersigned physician or supplier for the services described below. And we'll look at what's below here in just a minute. Now, if you are a non-par provider and you do not accept assignment, the patient pays you up front, box 13 should be blank. And if it's not, it could cause Medicare to pay you. And if the patient is already paid you, now you're double paid, and the patient, you have to refund the patient the money that they paid you. So please make sure that if you're non-par, no assignment accepted, box 13 is being left blank. The next section of the CMS claim form is the usually on the claim form itself. I don't know if you can actually see this. I might bring this a little closer to the mirror, to the camera, but there's this kind of solid red line about halfway through the claim form. So the top part of the claim form takes you through box 13. Then you have that solid line, and then the other half of the claim form relates to the encounter itself and the pay to entity, okay, who gets the check. All right, and so in the important fields that need to be filled out on a Medicare claim is box 14, which is the current onset date of the patient's condition. And the qualifier for that onset date is 4/31. If the patient has a chronic condition that you're treating, you also have to fill out box 15, which is qualifier 453, an acute manifestation of a chronic condition. So this is where you have, in order to prove ongoing treatment of a chronic condition, box 15 needs to be populated with qualifier 453 and the date of the acute manifestation of that chronic condition, okay? If you're using X-ray to prove subluxation, you need to place the X-ray date in box 19. And so you type in the words in whatever field it is in your billing software. There's usually a field for box 19 where you can type freehand. You would type in date of X-ray, right? And you could even say what the X-ray is, lumbar, 72100, or lumbar A to P lateral, date of X-ray, and that's what you would put in that, the actual date, so that they can prove that the X-ray is within that reasonable time, proximate time of the to justify medical necessity of that 12 months prior to or 3 months after the onset date. So in other words, that corresponds with box 14 is the date of the x-ray. Then your diagnosis codes. Now this is where you list all of your diagnosis codes, and you can and you can list up to 12 diagnosis codes here. Now you'll notice that it states in box 21, diagnosis or nature of illness or injury. And then it says relate A through L. You can see that each one of these fields has a letter, A through L, to service line below, and then in parentheses, 24E. So 24E is where you take a diagnosis code from this list and you let Medicare know what the chief complaint is based on that code. So let's say, for example, in Medicare, you are required to have subluxation as the primary diagnosis. So in this particular case, your primary diagnosis subluxation codes are your M99 codes. So, and typically the way you order your diagnosis codes in box 21 is your subluxation followed by the associated condition. So M99.03 followed by M54.50 lumbago, M99.01 followed by M54.2 cervicalgia. Okay. Now, I'm not saying that those condition diagnosis codes need to be lumbago or cervicalgia. If the primary reason for treatment is a chronic condition, then your B diagnosis code would probably want to be something in that long-term treatment, like a spinal degeneration code, cervical degeneration, disc displacement, etc. Because then that is going to be more supportive of treating a chronic condition than just a pain code, right? But you would want to make sure that the pointer in box 24E is always the primary being a subluxation and not one of the condition codes. That would automatically deny the claim because under the medical necessity requirements for Medicare, the treatment is limited to manipulation to treat a what? Subluxation. So that is really the only diagnosis code that should be pointed to the spinal manipulation. The other thing is Medicare only reads diagnosis code 1. So even you can point up to 4 diagnosis codes in box 24E, but the claims processing systems only read the first one. Okay, that's why it's so important when you're, let's say you're billing an x-ray or you're billing for an extra spinal adjustment. If your billing software program, let's say you have ChiroTouch or Eclipse or any one of these programs, Jane, whatever you're using, they will always default to the first 4 in the diagnosis code pointer list, unless you manually change that. So you have to manually change the pointer to indicate why you're treating the patient for that particular condition. So if it's 98943, and let's say diagnosis code G is your shoulder pain, right? And you did a manipulation on the shoulder, on the left shoulder, then it would be 98943, and the diagnosis code pointer would be G, not A, because A is for a spinal subluxation. So it doesn't make sense, right? So you have to make sure that you're using your diagnosis codes correctly. Now, if you are a non-par provider, that you set up the claim the same way, okay? The only difference is that in box 27, if you don't accept assignment, you mark no in box 27. Box 13 is left blank, and then the rest is, and then you place the limiting charge in box 24F, not your full fee, but the limiting charge. It's really the only time that you don't bill your standard fee on a claim form is when you are non-par with Medicare and you're billing the limiting charge. You can only bill up to the limiting charge, okay? Now, that represents the information about the claim. Also, box 24J is the NPI of the person who rendered the service. So this should be the NPI of the individual chiropractor, okay? As opposed to box 33 down at the bottom, which is the billing NPI, and that is the NPI that is assigned to the federal tax ID number in box 25, that is the pay to entity. So box 25 through box 33 is all about who gets paid, all right? And then also the signature of the rendering provider that certifies that this is a true and accurate claim, which is box 31. And that's typically, it'll just say signature on file, but that is the signature of the rendering provider needs to match the NPI of the rendering provider in box 24J, okay? And then the billing NPI needs to match the billing NPI of the federal tax ID number in box 25. So you may have two different NPI numbers on your claim. If you're billing under an LLC, for example, and your LLC is Acme Chiropractic LLC, or Dallas County Chiropractic LLC, then the pay to entity in box 33 is going to be Dallas County Chiropractic with the group NPI for Dallas County Chiropractic. And then your NPI is going to be the rendering NPI, you being the person who actually rendered the service, or your associate doctor, whoever actually rendered the service, and that needs to match box 31. So this is where I'm going to read something to you. In box 31, it states, I certify that the statements on the reverse apply to this bill and are made a part thereof. So essentially, the backside of the CMS 1500 claim form, and I know this is very, very light, but essentially it's a contract, okay? And I'm going to read the signature of physician or supplier certification statement. It says here, in submitting this claim for payment from federal funds, I certify that, number one, the information on this form is true, accurate, and complete. Number two, I have familiarized myself with all applicable laws, regulations, and program instructions which are available from the Medicare administrative contractor. Three, I have provided or will provide sufficient information and documentation required to allow the government to make an informed eligibility and payment decision. Number four, this claim, whether submitted by me or on behalf of my designated billing company, complies with all applicable Medicare and or Medicaid laws, regulations, and program instructions for payment, including but not limited to the federal anti-kickback statute, meaning I'm not discounting any services, and physician self-referral law, commonly known as Stark law. Number five, the services on this form were medically necessary and personally furnished by me or were furnished incident to my professional service by my employee. And this is typically for a medical doctor who has a nurse practitioner or a PA performing the service. This really doesn't apply to you. By me, under my direct supervision, except as otherwise expressly permitted by Medicare or TRICARE. Number six, for each service rendered incident to my professional service, the identity, legal name, and NPI license number of the primary individual rendering each service is reported in the designated section. For services to be considered, I'm not going to read the incident to part. So anyway, this is essentially you telling the federal government when you bill this claim out, number one, I rendered the service. Number two, the codes that I have placed on this claim form are accurate and true. Number three is that I have documentation to prove medical necessity. So this is one area where I must caution you significantly, okay? And the caution is this: do not submit a claim until you have a signed SOAP note. Okay, do not instruct your staff people to submit claims until you have completed your notes and your notes are signed. And if they are electronic notes, they are locked, signed and locked notes. If you submit a claim without a signed SOAP note, okay, or without a completed SOAP note, you are submitting a false claim and you are in violation of what's called the Lincoln Law or the False Claims Act. This is a very serious violation that could result in fines of up to $11,000 per claim line. So you have 6 claim lines, $11,000 per claim line. If you use all 6, that's a $66,000 fine per claim. All right. So this is like, I don't like being the fire and brimstone preacher, but I have seen this happen enough to know that this is a very serious issue. Please make sure your notes are done before you submit your claims. Okay. You have 1 year to submit. Your notes actually are supposed to be submitted and completed in a timely fashion. Medicare defines timely as within 1 week of the date of service. So if you're letting your notes pile up and you're letting your documentation pile up, and you do, you complete, you go home one weekend and you complete your notes like once a month, right? That is not cutting it, guys. If you do that, then don't bill the claims. And you could, in a documentation request or in an audit, when you finally electronically sign your notes, it's going to sign the note to the date that you completed it, not the date of service. So you have to make sure that your electronically signed notes are signed to that date. Now, your paper notes, can you backdate it? Yes, but it's a false statement. So I wouldn't recommend that either. So please make sure that this is very, very important, that you are completing your notes in a timely fashion. And that's the only fire and brimstone I'm going to give you. Okay. So when billing for chiropractic services, make sure that number one, you report the initial treatment date or date of exacerbation, okay? And that's going to be in CMS 1500 box 14 for the initial treatment date, box 15 on the date of the exacerbation. Specify the precise spinal location and level of subluxation. Now, part of that would be, box 21, where you do your M99 codes. That's going to give the region, but not the precise level of subluxation. That is documented in the patient's chart and available to the contractor upon request. Report the date of X-ray if an X-ray is used to demonstrate subluxation. That goes in box 19 of your claim form. Report the level of subluxation using the appropriate ICD-10 code. This is where you would do it in box 21. And again, the level of subluxation is going to be the spinal level, not the precise spinal location. So this is going to be cervical, thoracic, lumbar, sacral, or pelvic, using the M99.XX code appropriately to the different level. In addition to reporting the ICD-10 code, report any other pertinent ICD-10 codes. These are your secondary codes. And this would be following your subluxation code. So subluxation, condition, subluxation, condition, that would be your secondary DX. All your treatments and your documentation must be categorized as either an acute subluxation, a chronic subluxation, or maintenance therapy. And an exacerbation of a previous injury should be categorized into either an acute exacerbation or a chronic flare-up resulting in loss of function. So an identifiable re-injury would fall under acute. And again, that is not really reflected on the claim form other than in box 14 and 15, but this is where you would expound on it in the patient's chart. Excluded from Medicare coverage is any other service other than manual manipulation for treatment of subluxation of the spine. All right. And this is basically everything else. Your lab tests, x-rays, office visits, therapy, traction, supplies, injections, drugs, anything other than those 3 codes are not covered under Medicare Part B. The chiropractor is not required to bill for excluded services. However, if the beneficiary requests that Medicare be billed, the provider must bill services to Medicare in order to obtain a denial for secondary insurance purposes. And this is where you would put the GY modifier on any of these codes. Okay. If you have to bill for statutorily non-covered services, this is what it would look like. Okay, you would have your GY modifier on the exam code, the GY GP modifier on the traction code, and then, you know, everything else is pretty much the same. It's just that you bill with different modifiers. All right. We are going to go ahead and take our 15-minute break. We're about halfway through the class, and we're going to follow on the 15-minute break with billing for Medicare Advantage plans, because that's a little bit different than what we looked at in Medicare Part B. And we're going to go through the regulations to help you understand the similarities and differences in billing Medicare B and billing for Medicare Advantage. So we will come back at 10 till 11, and then we'll wrap things up. Thanks, guys. We're going to start up in about 2 more minutes. As you're coming back, if you would, please place your name and your license number in the chat box. Also, I noticed that one of the attendees just has the name of iPhone on it. We may not know who you are, so you may want to look at renaming yourself. I believe you can do that in the participants section, but let me see. Somebody raised their hand. Christopher. Christopher, you can unmute yourself if you want. Maybe you raised your hand by accident.
Christopher's all good. I think if as long as everyone puts their full name and license number in the chat, I think we're good to get going.
All right, fantastic. Okay. So let's get into a part of Medicare that there's a lot of confusion. There is a lot of misunderstanding around Medicare Advantage. And yet Medicare Advantage, as you know, and we've discussed, represents in some areas of Texas 55% or more of your Medicare population. So it's very important that you know what the Medicare Advantage billing and benefits rules are for this population of patients so that you're handling it correctly and in a compliant way. There is an IOM manual, internet only manual that CMS published, and I'm going to go back to the it's called the Medicare Managed Care Manual. This is published by CMS. And what we're going to be focusing on in this segment is Chapter 4, which relates to benefits and beneficiary protections. So it is what you'll be seeing on your screen is going to be direct copy paste from this manual. So it's not left up to interpretation. It's not what I think. It's not what I think we should do with Medicare Advantage. It is what the regulations are currently telling us. Now, there are revisions to this manual, and anything that is a recently revised segment of the manual is in red ink. Okay. So one of the first things that we see as part of the, and again, this is just snapshots of the entire regulation. I'm not going to read the whole thing. But one of the key elements of the snapshot is that it states MA. MA stands for Medicare Advantage. So we'll use the word MA when we're talking about Medicare Advantage. MA plans must provide their enrollees with all basic benefits covered under Original Medicare. That is one of the first statements of this chapter, okay? And what that means is that Medicare Advantage plans must cover spinal manipulation to correct a subluxation, period. And I know that I get questions all the time. Well, I got one last week on Friday, or yesterday, I guess, from a provider in North Carolina, and the same one in Georgia, not in Georgia, in Ohio, who said, is Humana not covering spinal manipulation anymore for Medicare patients? And I responded back saying, no, they have to. And if they're denying spinal manipulation, it's because they they're breaking the law. By law, Medicare Advantage plans must provide their enrollees with all the basic benefits covered under original Medicare. So undisputed, the 3 codes that are covered under Medicare Part B must be covered under the Medicare Advantage plan. However, okay, and there is a big however to this. It says Medicare Advantage plans are not required to provide Medicare Advantage enrollees the same access to providers that is provided under original Medicare. So you can be a PAR provider with Medicare B, and you could be not enrolled as a PAR provider with Medicare Advantage. And if that Medicare Advantage plan has no benefits out of network, then there are no benefits, right? So it's not that they don't cover spinal manipulation. It just means that because you, the provider, are out of network, there are no benefits, okay? And so that's a big difference that you have to distinguish. It's not whether it's covered or not, it's whether you as a provider are able to provide that service to the Medicare Advantage patient. So really what it's more about is it's more about provider enrollment than actual coverage. Coverage, at least the basic Medicare coverage, remains the same. Under the cost sharing portion of the regulation, it states, with the exception of the services listed at CFR 42 CFR 422.100, okay, and that's basically the basic benefits that we've discussed in Medicare Part B, and certain preventative services, MA plans may impose cost sharing for a particular item or service that is above or below the original Medicare cost sharing. So essentially what this is stating is that Medicare Advantage plans don't have to go with the 80-20 configuration that Medicare Part B does. They can have a copay for the spinal manipulation, or they can have a copay for chiropractic services of, let's say, $30, but if the allowable is $24, then the patient is going to have to pay the entire $24 out of their pocket, right? So essentially what it's telling you is that Medicare Advantage plans behave the same way a commercial plan would, in that they may have a copay, they may have a higher deductible than $283, they may have a different coinsurance amount. The Medicare Advantage plans have the right to impose a different cost sharing structure. It also states in the regulation that Medicare Advantage plans may require enrollees to pay higher cost sharing amounts for services furnished out of network. So there are certain services furnished out of network in which there are benefits, but at a higher cost share. Again, very similar to commercial claims, where if you're an in-network provider, the patient may have a $20 copay, but if you're out of network, the patient may have a $3,000 deductible with a 70-30 cost share or a 60-40 cost share. So MA plans have the latitude to do the same as far as impose different cost sharing. It also states that Medicare Advantage plans do not have to follow original Medicare claims processing procedures. They can create their own billing and payment procedures as long as providers, whether contracted or not, are paid accurately, timely, and with an audit trail. Now, what that means is that Medicare Advantage plans can have a different timely filing requirement than original Medicare. So original Medicare has timely filing of 1 year. You can file a claim up to 1 year after the date of service. Medicare Advantage plans can impose their own. So if it's a UHC Medicare Advantage plan, the timely filing is 90 days. The same way it's 90 days for UHC commercial plans. All right. Blue Cross of Texas, 180 days under their Medicare Advantage plans. So you have different claims processing procedures and billing and payment procedures that are not the same as the original Medicare plans. The other thing that is very different in Medicare Advantage as opposed to Medicare Part B is this concept of supplemental benefits. So a supplemental benefit is an item or service that is not covered by original Medicare. And a supplemental benefit cannot be part of a Medicare Part A or Part B covered service. So think about chiropractic. What is the Medicare Part B covered service? Spinal manipulation to correct a subluxation. 98940, 98941, and 98942. 3 codes and 3 codes only. So what this means under Medicare Advantage plans is if they offer supplemental benefits to patients, they may offer benefits for any other services other than those 3. So those 3 are covered because they must cover the spinal manipulation to correct a subluxation. That is the mandate, that they offer the same exact benefit as Medicare Part B, but they do have the ability to offer these supplemental benefits. And this is where you as a provider need to make the decision as to whether you want to entertain being in network with some of these Medicare Advantage plans, because in order for them to be competitive, it's not like Medicare Part B where you have one MAC, they have the contract, and they're not competing with anybody else for that contract. Okay, you're going to submit your claims, Part B claims, to Novitas, nobody else. Okay, now with Medicare Advantage, there could be multiple insurance companies within a service area vying for the business, the Medicare Advantage business in that service area. So you could have Humana out there, you can have United Healthcare, Aetna, Blue Cross of Texas. They may all have contracts in your service area, and they're competing for patients. One of the ways they compete is by offering supplemental benefits. So you will see, and you'll find if you're verifying benefits on Medicare Advantage patients, that in anywhere up to maybe 50% of the plans, they have supplemental benefits, which means the Medicare Advantage plans will cover that exam that Medicare B doesn't cover. They'll cover the therapies, they'll cover the x-rays. And so it's really important, if you're seeing or treating a Medicare Advantage patient, that your staff is verifying benefits to verify whether the patient has a basic plan, a basic Medicare Advantage plan that only follows Medicare covered service guidelines, or if they have a plan with supplemental benefits. Medicare also refers to this as routine benefits. It's kind of a misnomer because you would think routine benefits are just the spinal manipulation, but I don't know, it's the government. What can I tell you? They also call these supplemental benefits routine benefits, meaning for, I guess, routine care that is not covered over and above the Medicare benefits. One of the supplemental benefits that we have seen Medicare Advantage payers cover is maintenance. And I get calls all the time from billing CAs who are in an absolute panic because they billed Humana, let's say, or they billed United Healthcare, and the patient, and they left the AT modifier off the claim, so they billed it with no modifier, and the payer covered it. And they're like, why did the payer cover it if we left off the AT modifier? And the answer is because if you leave off the AT modifier, you're telling the payer, that the Medicare Advantage payer, that the patient is no longer in active treatment and is now in maintenance because, and when we get into the ABNs, the Medicare ABN is not valid with Medicare Advantage plans, okay? So the way you tell a Medicare Advantage plan that the patient is in maintenance is by removing the AT modifier and billing it with no modifier at all. So if you do that and the insurance company pays with no modifier, it means that the patient's supplemental benefit kicked in, and that supplemental benefit included maintenance care. Okay. So these Medicare Advantage plans could be a boon for you guys in depending on your patient populations and where you're getting your patients from, whether they have Medicare Advantage plans with these supplemental benefits. If you're not checking for supplemental benefits, you may just be assuming that the exams and the x-rays and the therapies aren't covered and you're not billing them, but you could be losing money that way by not billing them, because I know a lot of you, if you don't bill it, you don't charge the patient for it, or you charge the patient a very, very low fee. And that in and of itself has compliance issues. So under the supplemental benefit, you would be able to get reimbursed for that. There is a table in the managed care manual that shows chiropractors have access under supplemental benefits for what they call routine care or other, and other is referring to any non-Medicare covered service. The managed care manual actually addresses chiropractic services specifically. And it states in the manual that MA plans may choose to offer routine chiropractic services as a supplemental benefit, as long as the services are provided by a licensed DC and is furnishing the services within your scope of practice. The routine services may include, oops, sorry about that, let me go back. The routine services may include conservative management of neuromusculoskeletal disorders and related functional conditions, including but not limited to back pain, neck pain, and headaches, which means that the M99 code does not have to be primary in those cases, and the provision of spinal and other therapeutic manipulation and adjustments, and other therapeutic manipulation, meaning extraspinal manipulation. X-rays or other diagnostic, meaning exams or therapeutic services refurnished or ordered by a chiropractor may be covered by the MA plan as a supplemental benefit, as long as the chiropractor is licensed and it's within your scope of practice. So it's very, very clear that you could be having patients who have more benefit under Medicare Advantage plans than under the original Medicare plans. All right. So for those of you, this is a big question I get, and I want to really unpack this and spend a little bit of time on it. So I get a lot of questions about whether you are required to bill Medicare as an out-of-network provider or Medicare Advantage plans as an out-of-network provider. And the answer to that question is it depends, okay? And what it depends on is, it depends on the type of Medicare Advantage plan the patient has. So one of the things that you must do when you are seeing your Medicare Advantage patients is look at their insurance card. And if their insurance card says Medicare Advantage HMO, not any of these others, HMO POS, PPO, RPPO, MSA, and PFFS. These are all the different types of Medicare Advantage plans. If it says HMO and only HMO, it is very clear in the table that it states must provide in-network only. That means there are no out-of-network benefits. So if you are out of network with a Medicare Advantage HMO plan, and the patient has a straight HMO, not HMO POS, but straight HMO, you can very, very confidently tell that patient, we are out of network with your plan. Okay, we are not contracted with your HMO. Of course, verify that. Make sure you're not in network. We are out of network with your HMO, and because we are out of network, there are no benefits and you must pay cash. In that case, you do not have to bill the MA plan. You do not have to bill the Medicare Advantage plan for non-covered services in which there are no benefits. Okay, it's two criteria: non-covered, no benefits, right? Or out of network, no benefits. Now, if you're out of network with the plan and there are benefits and it is a covered service, you have to bill for it. Okay, so essentially, if the patient has an HMO POS indicator on their insurance card, if it's a Medicare Advantage PPO or RPPO, if it's a medical savings account plan or a PFFS plan, all right, it very clearly states that you must provide in-network, and under the HMO POS, it says must provide specific out-of-network. Specific out-of-network is the spinal manipulation to correct a subluxation. So covered, basic covered benefits, all right? Anything outside of that, therapies, exams, x-rays, you tell the patient, we are not in network with your HMO POS plan, and these, we will bill for you out of network for the spinal manipulation for active care. But again, you have to verify those out of network benefits, because if there is, let's say, a $3,000 deductible under that HMO plan out of network POS, right? Then you have to collect on that deductible. So the patient is still probably going to have to pay all of it out of their pocket. It's just that you are bound legally to bill for it. Okay, so you have to bill for it if it is out of network and there are out of network benefits. If it's out of network and there are no out of network benefits even under the HMO POS plan, and it states there are no benefits, then you do not have to bill. Okay, for any out of network benefits in which there are no benefits at all. In other words, they don't cover it out of network. Because many of you are going to be configured in the way that you may be par with Medicare B, but you're non-par with all of these Medicare Advantage plans. And so you have to understand that just because you're non-par with the Medicare Advantage plans doesn't, give you a free pass on billing on all of your codes. You do have to verify whether the patient has out-of-network benefits or not, what the cost share is, okay? Collect the cost share. But if there are out-of-network benefits and you are out of network, then you have to bill, okay? Same way with out-of-network, non-par Medicare Part B, right? You have to bill for the spinal manipulation codes 989401 and 2, even though you're not accepting assignment, all right? you would have to bill for them, okay? So if there is out-of-network coverage, you have to bill and collect the out-of-network cost share from the patient. Q&A. Can you not accept assignment with Medicare Advantage plans, i.e. the patient pays up front and MA pays the patient? Great question. And this is actually my next slide. So I'm going to just take you right on to this next slide. Well, next slide. Sorry, I lied. Okay, so just, but I'm going to get to that question. So Medicare bill, so in summary on billing Medicare Advantage plans, make sure you clearly understand the contracts under which you are in network and out of network. Always verify coverage and benefits on your Medicare Advantage patients. The only ones that I would say that you could get away with not verifying benefits is if the card says HMO and you know you're out of network. Then at that point, you can very confidently say, we are not in your HMO network. And as such, because this is an HMO plan with no out-of-network benefits, you must go to a provider in your network. You're going to have to pay cash. Okay, and you don't have to bill Medicare in that one case. Okay, but other than that, if it says HMO POS, if the card says PPO, RPPPO, RPPO, MSA, Medicare Savings Account, or PFFS, Private Fee for Service, then you would want to verify those benefits. Okay. Remember that most Medicare plans, well, or all Medicare plans really follow the Medicare guidelines, but some will have extended coverage. And Medicare Advantage plans do not recognize the ABN or the GA modifier. We'll get into that more when we talk about the ABN forms. If the patient has an MA plan, always verify whether they have Medicare covered or extended benefits. Okay. Medicare covered plans follow Part B guidelines. Extended or routine benefit plans may have coverage for things like exams, x-rays, rehab, extremity adjusting, and maintenance. The modifiers that you would use on your Medicare Advantage claims are your AT modifier for active treatment, same way as you would use it under the routine benefits. The GA modifier is not valid for MA plans because they do not recognize the Medicare ABN form. And be careful about using that GY modifier, because if the patient has extended benefits for the exams and the x-rays and the therapies, and you put a GY modifier on there, the Advantage plan will deny it as not covered when in fact it might be covered. And if you're going to bill maintenance, and maintenance is a covered service under the Medicare Advantage plan, bill the maintenance adjustment with no modifier at all. Okay. Medicare B and Medicare Advantage timely filing is 1 year for Medicare B, and for Medicare Advantage, it's payer specific, and that is from the date of service. Medicare B processing time for a clean electronic claim is 14 business days from the date it's accepted for adjudication. I'm not sure why the slide about the accepting assignment wasn't on this. I do apologize for that, but in the regulation, it states that the Medicare Advantage plan does not have to honor no assignment accepted. So what that means is that even if you mark no assignment, the Medicare Advantage plan in all likelihood is going to pay you. So your choice is as an out-of-network provider, you can collect the fee up front from the patient. You can do that, right? You can bill it, and you can leave box 13 blank on the assignment box, and you can leave you can put no in box 27. but the Medicare Advantage payer doesn't have to honor that. It's clearly stated that way in the regulation. So you may get double paid. And if that happens, then you would have to refund the patient any money that they paid you. So it's kind of up to you how you want to handle that. If you want to handle doing, basically no assignment accepted, because there are some Medicare Advantage payers that will honor that. And it's very, very arbitrary. So some will honor it, some won't. So if you wanted to, what you could do is out of network, no assignment accepted, you collect up front, you do your billing per the regulations. If it's a covered service out of network, you have to bill for it, right? But you don't accept assignment, you collect up front. If the Advantage plan pays you, you can't appeal that, okay? Don't bother. All you need to do then is maybe once a month, run a report of credit balances on your Medicare Advantage patients, double check and verify that the patient did get paid you and then you did get paid from the plan, and then just refund the patient that money to get them down to a zero balance, okay? So it's kind of how you want to handle that. You can verify when you're verifying benefits, you can ask, do you honor an assignment, a non-assigned claim, or do you require that, does your policy require that we be paid directly? And so that is something that you can verify when you're verifying benefits. So if you want to do that on the front end, or just monitor that on the back end, or just not collect from the patient until you've filed the claim and then balance bill the patient, I'm not sure that's a great idea either, unless you have a way to guarantee that payment, like have a credit card on file that you can automatically process to capture that payment when the EOB comes in. So some of the laws that may affect reimbursement, and there will be the sequestration, the government sequestration is in effect. It is a 2% mandatory reduction on your codes, the allowables, and it will show up typically as a CO 253 sequestration, reduction in federal payment. Medicare Advantage plans do also have sequestration, as well as Medicare Part B. Another area that can affect reimbursement of your Medicare claims is the Quality Payment Program, the Merit Incentive Payment System, or MIPS. Now, most chiropractors are exempt from this, unless you are in an area where you have a large Medicare population, or where you're seeing, I believe the rule is over 300 patients, or 90,000 in Medicare allowable payments per year. So there is a criteria to be involved in the MIPS system. If you want more information on that, or if you are finding that you're getting reductions under MIPS and you want to stop that from happening, essentially this merit incentive payment system, oops, sorry about that. Let me go back here. I don't know what it's doing. We lost the slide there. So under MIPS, you have to meet a certain threshold. I would say 90% of chiropractors do not, so this doesn't really apply, but just in case, you would check your current eligibility status, review your participation, understand your options, and what you need to do to participate in this program. Now, if you do qualify for this program, it could result in up to a 9% increase in your reimbursements, right? But it also could result in an up to 9% decrease in your reimbursements, okay? And the low volume threshold criteria has not changed since 2024. It is, you have to bill over 90,000 in billing, in other words, reimbursement, and then have over 200 individual Medicare patients. So for those of you that may have a very large practice with a decent Medicare population, you may be subject to MIPS. And these are and, so you have to meet all that criteria in order to be subject to MIPS. To determine if you're eligible, you can go to the QPP website and check your eligibility by practice year. So now it's going to have 2025 in there, so you can check all years to see what your participation status is, whether you are exempt or not. Everything that determines eligibility is based on what you did 2 years ago. So 2025 eligibility is based on your 2023 numbers. 2026 eligibility is based on your 2024 numbers, and so on and so forth. These are the websites that you can go to check on your status under the quality payment program and to determine whether you're eligible. And if you are, the QPP website gives you instructions on how to do your reporting. Some of it is done through claims, some of it is done through your software. And so it'll give you specific instructions on how to do that so that you can apply for an increase in your reimbursements. All right, any questions on Medicare Advantage billing? Check the chat real quick. I just see names and license numbers. Okay. All right, let's talk about coordinating benefits. I think one of the areas where, you know, as you know, Gold Star Medical, our company, it does medical billing for chiropractors all over the US. And one of the big things we struggle with as a billing company is when the front desk CAs, because the vast majority of our clients are chiropractors and medically integrated practices, when CAs or you know, in a medical setting even, the medical assistants or the front desk receptionists who are inputting the insurance information into the billing systems that we use don't know how to properly read insurance cards and coordinate benefits, okay? I have a webinar that I teach called What Every Front Desk CA Needs to Know About Insurance, and this comes from part of that, okay? And the reason why this is so important is because if your CAs don't understand, or your billers don't understand coordination of benefits, you could be billing the wrong insurance company for the services that you're providing. And then what happens is if the wrong insurance company is billed, then it gets denied, it comes back to you. Now you've wasted however much time it took for the insurance company to tell you that, no, you're billing it to the wrong insurance company. And now you've got to figure out, well, what is the right insurance company? And you have to backtrack and then rebill to the correct insurance company. And so it could delay your payments. And in some cases, the staff are so uneducated about this, is they don't know what to do, and they don't reassign the benefits to the correct payer in time to meet your timely filing requirements, okay? So this is a very serious issue. And honestly, when we take over, let's say, you know, we take over billing of a provider, one of the first things we look at is we go into your clearinghouse and we look for claims errors in which there was incorrect coordination of benefits. And so we're going to look at this in a little bit of detail so that you can make sure that your CAs are properly trained on this in this matter. So for Medicare, every single patient that becomes eligible for Medicare receives a red, white, and blue card, okay? And it lets you know whether the patient has Part A and Part B or just Part A. Sometimes you'll get a Medicare health insurance card and it'll just say Part A and it won't say Part B. Usually in those cases, when it doesn't say Part B, it means the patient is still employed somewhere and they've deferred Part B, and they still have commercial insurance for their medical services. They automatically become eligible for Part A, but they have opted out of Part B until such time as they fully retire. So sometimes you'll see only Part A on the card. And if you see that, then you have to ask the patient, do you have other insurance for your medical services? And you get their employer's in card or whatever. On very rare occasions, you have patients, and you're not going to see this very much anymore because of Medicare Advantage, but it used to be that patients before Medicare Advantage would absorb the cost of the Part B premium. Some patients who were indigent would have Part A, and then they would not have Part B, and they would only have Medicaid. Well, that's that doesn't happen anymore. Okay, so you typically don't see that. But if a patient has opted to replace Part B, they're still going to have this card that says Part A and Part B. This does not mean that you're billing original Medicare. You're still going to have to verify benefits to see if this Part B indicator on their card has been replaced with a Part C plan. Okay. Now, if the patient has Part B, original Medicare, many patients will choose to purchase an additional supplemental plan. We talked about that last week. And this is what an insurance card of a supplemental plan might look like. It will say supplement, Medicare supplement with a plan letter. And this is what is known as a true Medigap plan, meaning that this supplemental plan gaps the coverage of Medicare Part B. So what is the Medicare Part B coverage? Original Medicare, a $283 deductible, and then the Part B contractor pays 80% of allowable charges, and then the patient pays 20%. So that 20% and the deductible is what is gapped under the supplemental plans. Now, only Plan F and Plan C, Charlie, will gap the deductible. All the other plan letters, Plan L, Plan K, Plan N, so it goes A through N, all right? So only C and F are going to cover the deductibles. So if you have a patient that has a Medicare supplemental Plan K, they still have to meet that $283 deductible before the Medigap payments start covering that 20%. And it's only going to gap covered services. So I don't know if this has ever happened to you, but when I was working as a CA, it happened to me all the time, where we would have patients come in and they would, we would tell them the only thing Medicare pays for is spinal manipulation when you have an acute injury or a chronic, or we're treating you for a chronic subluxation. And then the patient says, well, I have secondary insurance. And we have to explain to them, when we look at their card, we see that it's a Medigap. We tell them your supplemental plan only gaps coverage on covered services, because x-rays and therapies and exams aren't covered, your supplemental plan won't cover it either. And then they get all hot and bothered about it and they say, well, I want you to bill Medicare and prove it to me. So then at that point, that's when, because they asked you, you bill Medicare for the non-covered services, you put the GY modifier on that, they'll cross it over to the supplemental plan and the supplemental plan won't cover it either, okay? So the supplemental plan only gaps covered services, right? So this is the from the Medicare, this actually comes from the Medicare and You booklet that we talked about last week. And it's a great chart. This makes a really good cheat sheet for your CAs. Some of the providers in the past have taken this page of notes and have copied just this page and laminated it, given it to the CAs to keep at the front desk so they can use it as a quick reference guide on what these Medigap plans will gap. So you'll notice Plan F and Plan C shows that they pay 100% of the Part B deductible. And by the way, Plan F and Plan C are no longer offered to new enrollees, okay? They're no longer for sale, but they are grandfathered. So, probably within the next, every year you're going to see fewer and fewer of these plans because I believe they were grandfathered about 10 years ago. They haven't been sold in a long time. And so as patients die, there are no more new plans being offered that cover the deductible 100%. So under all the other plans other than the deductible, you have to collect the $283 if they haven't met it somewhere else. And then it gaps 100% of the coinsurance. So 100% of the 20% that's left is what is covered at 100%. And remember, it's only for covered services. Plan K and Plan L do not cover 100% of the 20%. Plan K only covers 50% of the 20%. And Plan L only covers 75% of the 20%. So the patient still has, in Plan Ks, they still have a 10% coinsurance that they have to meet, okay? And so just be aware of that. There's still going to be a little bit of an out-of-pocket cost for the Plan K and the Plan L. Now, some retirement and union plans provide true secondary policies. These plans may offer the expanded benefits like exams, x-rays, and you'll notice like this one that you're seeing right here, the Blue Cross Blue Shield example shows PPO with a suitcase. It doesn't say Medicare Advantage. So this is not a replacement policy. Otherwise, it would say Medicare Advantage. So this could be an indicator of it. It doesn't say Medicare Supplemental Plan F. It's just an insurance card. So when you have a patient that brings in a Medicare card and then an insurance card like this one, that does not indicate anywhere that it's a Medicare supplement or a Medicare replacement or Medicare Advantage plan, then you need to verify two things, right? One is this plan primary to Medicare, or is Medicare now the secondary payer and this is the primary payer, or is this secondary? And if it's secondary, does it cover other services besides just the spinal manipulation? All right. And so if it is a Medicare Advantage plan, it will state, so it'll say like this one says MAPPO, Medicare Advantage. It will show at the top Blue Cross Medicare Advantage PPO. So this is what a sample card might look like, okay? Blue Cross Blue Shield of Texas employees have a certain population in which they did not contribute 40 quarters to Medicare Part A. Your teacher's retirement system is administered through Blue Cross Blue Shield of Texas. Alpha prefixes T2U, T3X, and T2S. These are Medicare replacement plans that cover A, B, and D all in one plan, okay? You also have state university system retirees who have alpha prefix ZZT. So if you're in an area like the UT area where you have retired teachers, ZZT, these are going to be under TRS Care, which is the Teachers Retirement System of Texas. Also, state of Texas retirees have Alpha JEA, JNA, JXA, JVA, and JYA. All of these alpha prefixes are for retired populations are Medicare Advantage plans. So be aware of that. You also may be treating dual eligible beneficiaries. So these are individuals who are eligible for Medicare and they receive Medicare and Medicaid benefits. Now, a dual eligible patient, Medicare, in the dual eligible population, Medicare is always primary, okay? And it doesn't matter whether you take Medicaid or not. If Medicaid covers the spinal manipulation to treat a subluxation code or not, if you're treating a dual eligible patient for 989, 40, 41, or 42 with an AT modifier, you cannot balance bill them for the 20% coinsurance. Okay. Now, under Medicaid, if the patient has Medicaid and you're billing them or you want to provide non-covered services, you may let them know ahead of time that you do not participate in Medicaid, that Medicaid has no benefits for these exams and these other services, and that the patient would have to pay cash, but you must do it before you render services. So this is what the Medicaid card would look like. So sometimes the patient will bring in the red, white, and blue card and then a Texas Medicaid card. Typically, it's going to let you know the type of plan that it is. Somewhere on the card, it's going to state QMB, Qualified Medicare Beneficiary. SNP is a special needs plan for certain special populations. It may say dual eligible. And if the card says dual complete, it means that the patient has a Medicare Advantage plan that also has Medicaid benefits. Okay. And then you have the Star Plus plan, which is a Texas Medicaid Managed Care program for individuals with disabilities or Medicare dual eligible patients who have opted to go with a Medicare Advantage plan instead. Okay. So what else can the insurance cards tell you? It can tell you the type of plan. So this is the TRS, Teachers Retirement System Plan. TRS Standard, they have Standard and Ultra. And so if you go to Blue Cross Blue Shield of Texas, you can look up all the benefits for the TRS standard plans, what the copays are, what the deductibles are. So you don't have to verify benefits every single time. You can go by the plan limitations and it will tell you, and then it will tell you what the deductible is, both in and out of network. It will tell you medical services. It will tell you telemedicine services, etc. It also lets you know if it's a PPO or an HMO plan. And remember, if there's a suitcase on the card, it means there are traveling benefits, meaning that the patient can have benefits outside of their service area. So if a patient has a Medicare Advantage plan, be sure to never enter this card in the billing system. Just keep it on file, okay? So this is not the primary plan that you bill. You don't bill this plan at all. In other words, you're not billing Novitas as the primary and the Medicare Advantage as the secondary. The Medicare Advantage is the primary, and this is informational only, okay? Now, Medicare occasionally may be a secondary payer, and instances to understand when Medicare is secondary and when they're primary is dependent on the type of employer the patient has. So this is a question you would want to ask them. So if they bring you a Medicare card and then a commercial insurance card that does not indicate that it's a Medicare Advantage plan, okay? One of the things you would ask them is, where do you work? Okay. And if they work at Boeing, for example, or if they work for Dell, then they have there's over 65 employees in the area. Okay. And if they're 65 plus and there's over 20 employees in that group, then the group health insurance is primary, Medicare becomes secondary. If they're working for a smaller company, let's say they're working for, Austin Floral Services, and it's a flower shop, and they have the, insurance through that shop, and they have 10 employees, then their Medicare is primary and their commercial insurance is secondary. If it's disability, if they're under 65 and they have a disability, then the employee number jumps to 100. So 100 employees is the threshold. So if the patient is on Social Security disability, okay, or they're under guardianship of a parent who offers their insurance, and the parent works, and the patient has Medicare under Social Security disability, but the parent, for example, works for a company with over 100 employees, then the group health is primary. Okay, so that's how the primary secondary works. You can also look that up on Novitas, in Novitasphere, the provider portal of the Novitas website. You can determine whether Medicare is primary or secondary by going to the eligibility tab. There's a little sub tab under that called MSP, Medicare Secondary Payer. If you click on that tab, it will tell you if Medicare is secondary to the group health plan. Okay. Other instances in which Medicare would be secondary is if it's under work comp, or if it is under liability, like a PI claim. So if it's a work comp claim or a PI claim, Medicare becomes secondary to that, to those claims. Okay. So just doing a little quick exercise. You've got a patient, they walk in and they bring you these two cards. In your mind, and I know normally when I'm doing this live, I have you call it out, which one is primary and which one is secondary. So meaning when you profile it in your billing system so that you're billing it out accurately, how do you profile it? So in this case, it's pretty straightforward. This is a patient with original Medicare. Because they have a Medigap plan, you know that they have original Medicare. So the Medicare supplement plan is secondary. All right, that's a Medigap crossover. And what that means is that on the Medigap plans, you don't even have to bill the secondary. Medicare automatically forwards that claim information to the supplemental payer for reimbursement. Okay. Here's one. The patient brings you a Medicare card and a Blue Cross card. They're employed at the local florist shop and they have 10 employees. So is Medicare primary or is Medicare secondary? In this case, because the employer has fewer than 20 employees, the local florist is, even though they have insurance through the local florist, their Medicare is primary and their commercial plan is secondary. Okay. And it's possible that in this case, it's a true secondary plan with extended coverage for exams and x-rays and therapies. So check the benefits on that. Now, what about this? This is a Medicare, Medicaid patient, all right? And we call these dual eligible. So in this case, Medicare under dual eligible rules, Medicare is always primary, Medicaid is always secondary. What about this one? This is the teacher's retirement system. And we know that because the teacher's retirement system replaces Medicare A and B, okay? This is a Medicare Advantage plan that replaces A and B under the teacher's retirement system. So now what about this one? The patient brings you the Medicare card and then another insurance card, and Regis Logistics has 60 employees. In that case, Regis Logistics is primary, Medicare is secondary because they have over 60 employees, and this patient is over the age of 65. What about this mess? Okay, they bring you and this is what you get a lot, right? You've got a dual eligible Medicare, Medicaid patient. They have a Medicare card, they have a Medicaid card from the state of Texas, and then they have their Medicare Advantage dual eligible card, okay? And so in this case, the Blue Cross Medicare Advantage is primary, the Medicaid is secondary. And it's really the only time that a Medicare Advantage patient is going to have a secondary benefit. This is an auto claim. So for an auto claim, the State Farm or whatever farmer's insurance is primary, Medicare is secondary, and same thing with work comp. Okay, do we have any questions before we move on to the ABN forms? See if anything's in the chat.
Hi, Lisa. We have a couple questions. One is, would you please review ABN usage relative to when it's needed and when not needed?
Absolutely. That's what's coming up next.
Okay, well, before we do that, then let's look at, can you not accept assignment with Medicare Advantage plans, i.e. the patient pays up front and the MA pays the patient?
The MA plan, like I said, the MA plan is probably going to pay you, all right? And so even if you're out of network, the MA plans do not, because they have the ability to process claims differently than Medicare, than traditional Medicare, they can, in their policies, say, we do not honor a non-assigned claim. We're going to pay the provider no matter what, in network or out of network. So you're going to have to verify benefits on that one to verify whether an assignment or a non-assigned claim will be honored, or whether the payer's policy is to pay the provider no matter what, whether it's in or out of network. Okay.
Those were all the questions.
All right. Okay. Let's get into ABNs. Oh, so many questions about ABNs right now. So let's talk about what ABNs are. ABN stands for advance, and advance is the key word, guys. Beneficiary notice. It is used to inform patients that certain services and procedures may not be covered, and as such, the patient would be financially liable. And I will tell you, ABNs are not indigenous to chiropractic. They're used in all kinds of practice settings. We do billing for a lot of different types of specialties, and we use ABNs in many, many different situations and scenarios, okay? ABNs can also be used by commercial payers and Medicare Advantage, but not with the form that we're going to be looking at. And I'll be showing you an alternative form that you can use for Medicare Advantage and for your commercial payers if you have to make an advance notice of non-coverage. So failure to notify a patient in advance that a service might not be covered would or could result in you having to write off the entire claim if it's not paid. Now, there is a policy booklet on how to fill out ABN forms and how to properly apply your ABN forms, okay? It's through the Outreach and Education Medicare Learning Network. The link for the full document is on the bottom of this slide, okay? And I also have the full document available as a PDF, so you can email me. And at the end of our presentation today, I'll be giving you my email address, and just in case you don't see it, it's info info@goldstarmedical.net. You can email me and say, Lisa, please send me the Medicare ABN booklet, and I will also be able to send you the templates that you're about to see, the ABN templates on how to fill it out, how to fill these different ABN forms out correctly. So the current ABN form is the version CMS R131, which is set to expire on 1/31 of 2026. Now, I will tell you, the new one is not out yet. It has not been released. It has not been issued. It probably will not be released before the end of January. Medicare has placed a directive that in the absence of a new form, you continue to use this form until the new one comes out. And then once the new one comes out, you have 60 days to get everybody moved over to the new form. So basically on your active patients, once the new form is out, you're basically going to, as your patients come in, you're going to have them sign a new ABN form, okay? So the grace period for the validity of this form is 60 days after the new form comes out, but it has not come out yet. Okay. CMS generally recognizes 3 events known as ABN triggering events in which you have to furnish an ABN to a beneficiary prior to furnishing items or services. Now, one of the things to remember about the Medicare ABN form is that it is only valid with original Medicare, Medicare Part B, all right? And it is only valid for covered services, which are your 3 spinal manipulation codes, okay? So keep that in mind when we're looking at the examples of these ABN forms. So the 3 events that would trigger you to have the patient sign an ABN is at the initiation of care, and there's a little bit of confusion on this because it doesn't mean when the patient first comes in. It means that at the first encounter, if you feel that the patient is a maintenance patient from the get-go, you would have them sign an ABN form, okay? But if at that first treatment, the patient is going to be under active care, you do not have them sign an ABN at the very beginning. That invalidates the ABN, okay? The next triggering event is a reduction. That means you have to issue an ABN to a beneficiary if there's a reduction in their care plan and the patient would like to continue receiving care that you consider to be no longer medically reasonable or necessary, and then a termination of care. So you have to issue an ABN if there is a discontinuation of certain services and the beneficiary decides they want to keep receiving care that's no longer medically reasonable or necessary. So here's the scenario for an initiation. You have a new patient come in, they're transferring to you from another chiropractic office, and they have been a long-time chiropractic patient, right? They have a history of once-a-month treatments by their former chiropractor, and they're moving into your service area. They're looking for a new chiropractor, but they've been a wonderful maintenance patient for years, okay? You examine them, you find no evidence of subluxation that's affecting function or a patient's daily living. They're not in a lot of pain. They just recognize the benefit of routine adjustments. Any treatment you give them at that point is maintenance, okay? So they're coming in as a maintenance patient and you're continuing them as a maintenance patient. So they're initiating care with you from the very first time as a maintenance patient. That is the initiation triggering event that would warrant you to do an ABN for. A reduction would be where you have an established patient and they've been on a plan of care for 12 weeks, starting with 3 times a week for 4 weeks, and you do your reeval at 4 weeks and they're doing great. So the rest of the care plan, the 2 times a week for 4 weeks and the 1 time a week for 4 weeks, you believe at this point is really maintenance, okay? You've done as much as you can for them from a corrective standpoint. Now, anything else you're going to do is supportive. You have to notify the patient of that. You let them know that Good news, bad news. Good news is that you got better a whole lot faster than we expected. Bad news is now Medicare is going to consider this maintenance. So we need you to decide what you want to do. Do you want to continue treatment under maintenance, which means this is your cost out of pocket, or do you not want treatment anymore? And you show them the three choices, which I'll go over with you in a few minutes. And then the termination is that the patient has been on a plan of care. They've completed the entire plan of care, and now you're recommending supportive care to that patient. Then at that point, you would have them sign an ABN. Starting October 1st of 2021, you have to, Medicare requires you to use the most updated ABN form. They also state that as of October 20, prior to July 14th of 2021, you used to have an ABN signed every year at the beginning of each year or every 12 months. Now they state that a valid ABN will remain in effect indefinitely as long as there's no change in the patient's plan of care. They're on maintenance forever. Their health status, like a new diagnosis. There are changes to the coverage guidelines, of course. And if any of that happens, then the supplier has to issue a new ABN. So let's say the patient's been on maintenance and now they come in with an exacerbation or they've re-injured themselves and they have to go under active treatment. So in that case, the ABN is set aside, the current one is set aside. You start billing with the 18 modifier, and then at the end of that little micro treatment plan that you put them under, you reissue an ABN form and put them back into maintenance care, okay? So an ABN it does not have to be done. You're not supposed to do an ABN at every visit, because then what you're saying by doing that is if you have the patient sign the ABN at every visit, you're telling them that every visit is maintenance. All right, that's wrong. You don't want to do that. You don't have to do it once a year anymore. The only time you have to have them sign a new ABN is if there's a change in their treatment plan and they're coming in and out of maintenance care. Once they're brought back into maintenance care, you have them sign an ABN. Okay. Or if the form changes. So if the form is revised and there's a new expiration date, then you'll have all your patients re-sign an ABN, whether they are still in maintenance or not. So it's only for Medicare Part B, only for spinal manipulations. Any other services fall under something called a voluntary ABN, and I'll show you what a voluntary ABN could look like. You don't have to put a voluntary ABN on the form, the 131 form. You can. To me, it's a little bit messy, but you can, and I'll show you what it looks like. Always use the most current form, which right now is the one that says with an expiration date of 1/31 of 2026. If you have any ABN forms in your patient files that are an earlier version than that, at least get them signing the new form, right? Otherwise, it's invalid. Issue the ABN when you believe Medicare will stop paying, not just at the beginning of the treatment plan, okay? Issue the ABN if you feel there is a new treatment plan or, when there is a new treatment plan or new diagnosis, and now the patient is moving back into maintenance and it is no longer necessary to fill out annually. And as I stated, as of January 10th, the new ABN has not been published. You can use this form until Medicare releases the new form, and then you have 60 days. So if you are a PAR provider with Medicare, this is what your ABN should look like, all right? Where it says notifier, you place the name of your clinic. In anywhere you see section D or the letter D, you place the word treatments. And in box D, you have your 3 spinal manipulation codes that are covered by Medicare. In section E, under the reason Medicare may not pay is the statement of coverage. Medicare only covers chiropractic treatment to correct a spinal misalignment, i.e. subluxation, Maintenance treatment is not a covered services. In box F, you place your full fee for service, not the Medicare allowable, okay? At that point, once you've set up your form and you're issuing the form to the patient, you explain the ABN to them and you let them know that they have to choose an option from section G. And you tell them, we cannot coach you into this. We can't tell you what option to choose. If you do, it invalidates the ABN, okay? So please don't tell all of your patients to choose option 2 so they can pay cash, because the second you do that, then you're invalidating the ABN. You ask them to read the 3 options, tell them that if they have any questions about what it means, you can explain it to them, but you cannot coach them in any way, shape, or form. Once the patient chooses an option, then they sign and date the form. You put one in their file, make a copy of it, give them a copy of the form, and then keep one on file. If they choose option 1, they're saying that they want the treatment and they want Medicare billed for an official decision on payment. This is where you're going to continue to bill Medicare and you're going to change your modifier from AT to GA. If the patient chooses option 2, they're saying, I want the treatment, but don't bill Medicare. I'll pay cash. Okay. And then option 3 is, I don't want the treatment at all. And then at that point, you make a note that in the patient chart that they are releasing themselves. They do not want the treatment unless it is active treatment, and you send the patient on their way and you do not give them another appointment. You don't do any follow-up with them other than letting them know that you may call them in 3 months to see how they're doing. Okay. If they choose option 1 instead of an AT on the claim form, you're going to change that to a GA modifier. If you are non-par with Medicare, your ABN looks a little different, okay? It's the same up top. So the, box D, E, and F is the same, no issue there. The thing is if you do not accept assignment, you have to cross out the statement in option 1 that says if Medicare does pay, you will refund any payments I made you, less copays or deductibles. Well, the patient is already paid, so it doesn't apply. So you have to strike that out. And then in section H, you have to type the statement that says this supplier, that's me, the provider, does not accept payment from Medicare for the items listed in the table above. If I checked option 1, I'm responsible for paying the supplier's charge directly to the supplier. If Medicare does pay, Medicare will pay me, the patient, the Medicare approved amount, and this payment to me may be less than the supplier's charge. That exact statement needs to go on your ABN as a non-par provider that does not accept assignment. If it's a dual eligible patient, this is the only time that you have to tell them that they must choose option 1. Option 2 and 3 do not apply to the dual eligible patient, so you have to strike all that out. And then in section H, you have to type dually eligible beneficiaries must be instructed to check option box 1 on the ABN in order for a claim to be submitted for Medicare adjudication. Now, this is an example of a voluntary ABN form, and this is where you put the kitchen sink, right? All of your other non-covered codes. And you can put all your codes in that one box, but man, that's a lot of codes. So you can put your non-covered codes. It basically says in box E, these services are not covered when performed, supervised, or ordered by a doctor of chiropractic. You will be financially liable for these services, not maybe, but you will be. And then you could put a range of fees based on the categories, like your exam range fees and your x-ray fee range and your PT range. But again, it's pretty messy. You also have to strike out all the options because the patient does not have to choose an option under the voluntary ABN. And in section H, you have to type in, this notice is for informational purposes to inform you of your financial responsibility should you choose to have these services. You're not required to select an option from Section G. There is an alternate to this, and it is called the Notice of Medicare Non-Covered Services. And essentially, it just explains that the only service covered by Medicare Part B is spinal manipulation to correct a subluxation. And then in bullet point 2, it says all other services that are performed or ordered by a doctor of chiropractic are not covered. And so it's more written in like a financial policy type. I like this one better than the voluntary ABN on the CMSR 131. Technically, you don't have to give the patient either one of these. You can just tell them, verbally that nothing else other than spinal manipulation to correct a subluxation is covered. But if you want something in writing to prove that you told the patient this so they don't come back and argue that they were never told that they would owe this money, you can have them fill out this voluntary ABN form. You can get the ABN templates directly from Medicare, or you can send me an email at info@goldstarmedical.net. I can provide them to you in Word document format so that you can customize it for your practice and create a template. And it is also available in Spanish and in large print for those patients with low vision. Now, Medicare Advantage plans do not honor the Medicare ABN form. Some Medicare Advantage plans do cover maintenance and some have routine benefits. And so you have to follow your payer's rules for advance notice of non-coverage. So every payer get on their website and look for any policy on advance notice of non-coverage, okay? So basically, like this comes from Aetna. It says, providers should be aware that ABN document is not a valid denial notice for a Medicare Advantage member. The original Medicare program uses ABN documents, sometimes called waivers, but you can't use them for patients in Aetna Medicare Advantage plan since CMS prohibits them. So this is a rule that comes from CMS that they are not valid with Medicare Advantage plans. It's not a Medicare Advantage rule, okay? And so it tells you how to get and how to do an ABN with Aetna, okay? So essentially, it tells you that providers in a Medicare Advantage plan can't charge a Medicare Advantage member for a service not covered unless that member gets a pre-service official denial notice of denial from us before getting such services. Now, the OD notice of denial can be the patient's benefit summary that says these are the covered services and these are the non-covered services, okay? Blue Cross says you may not bill a Blue Cross Medicare Advantage PPO member for a non-covered service unless you've informed the member in advance that the service is not covered and the Blue Cross Medicare Advantage PPO member has agreed in writing to pay for the services if they're not covered, okay? And it gives you the same rules for the balance billing on the HMO plans. So again, the individual payers have these policies written somewhere, so make sure you know what these policies are. This is an example of a generic ABN notice that we have. This actually came from Blue Cross Blue Shield of Texas. They have it on file. We use it with other payers and for other types of services. So we also use it for services like spinal decompression or shockwave that's not covered. And you can give a patient, and you're supposed to give a patient advance notice and give them a good faith estimate of the services in order for those to be covered. So this can be used in Medicare Advantage, some Medicare Advantage, and some commercial applications as well. Okay, any questions on this? Relative to the ABN on top right, which exact identification number is required? The patient's Medicare number. Thank you for asking that question. All right, I think that's the only one. Do we have any hand raises? Let me see real quick. I don't see any hands raised. Okay. All right, we're going to finish up with Medicare claims investigation. So this is the part that we just talk about Medicare audits and how Medicare claims are investigated and audited. First of all, if you have any issues with your Medicare claims that are Part B, you can call Novitas Solutions. This is their customer service line, and they are open from 8 to 4 every day, Monday through Friday. Okay. It's going to be hard to get through. I'll just tell you that right now. So you want to make sure that everybody in, that handles billing for your Medicare patients, your Medicare Part B patients, has access to Novitasphere. Novitasphere is their e-services portal, and these are all of the things that you can do in Novitasphere. You can check eligibility and benefits. You can check claim status. You can find EOBs. You can conduct your first level appeals through redeterminations, and you can submit medical claims attachments, meaning if there's a request for records, you can send in your records through Novitasphere. So this is a pretty much mandatory portal that you need in order to completely and fully function in Medicare Part B in the state of Texas. To get to Novitasphere, you go to the home page. At the top right-hand corner, there's a link to Novitasphere, and you would click on that link. If you've never set up an account, there is an initial enrollment option that you can follow, or there is a login option that you can just log into. Everybody needs their own Novitasphere account. You can't share because of multi-factor authentication. And please, if you've never set up Novitasphere, make sure that whoever the admin is in Novitasphere is not going anywhere. Do not let your CA be the admin, because if they quit, right, you will not be able to get into Novitasphere to add users or remove users or do anything, change passwords. So your admin should be either the provider or maybe the provider's spouse or partner, somebody who is not going anywhere anytime soon, okay? Then you would have your staff members, your billing team. If you have a biller like a billing company, we become end users on your admin account. So you have an admin, that's the first thing you set up, and then you have your end users. And so the admin needs to be somebody stable and permanent in the practice. Otherwise, it's a bugaboo to get that reassigned, and it really takes a while and can cause a lot of delays. All right. So to investigate your unpaid claims, make sure that your staff or your biller, your billing company is running a monthly AR report, aging it out, looking for claims that have fallen through the cracks and that are in at least 30 days outstanding. Now, remember, Medicare Part B, if the claim is a clean claim, they're going to pay it in 14 days. So anything over 30 days bears investigation. I wouldn't wait 60 days, okay, like you do with some other payers, because Medicare pays in 14 days. And so if your claim is out there outstanding over 14 days, look and see what the problem may be, because they should have already paid it, okay? Set up your portal access, not only to Novitasphere, but to all the portals in which your Medicare Advantage claims may land, like Availity for your Blue Cross, your Aetna, and your Humana claims, United Healthcare Online. Check for claim status first, and then your phone call should be the last resort. Everything nowadays is done electronically on your portals and on your sites. If you've not found a claim on file, then do some forensic investigation. Look at your billing software, and did it even leave the building? Was it ever billed out? If it was, did it get hung up somewhere like at the clearinghouse, or did it get rejected back to the payer? And so look for these types of rejections so that you'll know what kind of activity to take. Medicare EOBs are very standardized, so the explanations on the EOBs as to why a claim doesn't get paid are used on in any Medicare MAC. So the terminology are CARC and RARC codes, and this isn't a billing class, so I'm not going to get into it too much, and we are down to our last 15 minutes. So, but CO, that indicator is a contractual obligation. That means that it is your contractual obligation to make any corrections or write off the uncollectible balance. A CO doesn't automatically mean a write-off, so be sure that your staff isn't doing that, just because they see a CO, they're writing it off. It's not a contractual obligation to write off, it's a contractual obligation to attend to or address the issue. OA is other adjustment. So OA 22 means the healthcare service may be covered under another insurance provider. So they're letting you know that you billed Medicare Part B, but that usually means that the patient has a Medicare Advantage plan. And so it was erroneously billed to Medicare Part B. CO4 could be a missing or an incorrect modifier. These are just some common ones that we see on EOBs when there are claims denials, okay? OA 18 is a duplicate claim. And then CO 97 is a bundled service. So that means there may have been an error in diagnosis code pinpointing or a failure to add a modifier when one was needed, okay? So you'll know, like CO4, it says a missing or incorrect modifier. Well, you don't write that off, right? So you don't write it off just because there's a missing modifier. No, you go in there, you do whatever corrections you have to do, and then you submit your corrected claims. All right. Under Medicare appeals, Medicare has 5 levels of appeals. Now they have reopenings, which are clerical reopenings that can be done for minor errors like transposed diagnosis codes, inaccurate data entry. And these are usually what they call RTP, or return to provider. So the return to providers are claims that have errors that are returned to you that have billing or submission errors. Typically, these will be accompanied by what's called a CO16, meaning that the claim has submission errors and cannot be adjudicated. It has been received by Medicare. Medicare sees something wrong immediately. They don't even bring it into the claims processing system, and they kick it back to you as an RTP claim. Those claims can be corrected, right, at any time, and then they just need to be resubmitted. So you don't have to do any kind of a special appeal or redetermination. You simply correct the claim. Now, once a claim has been adjudicated, meaning the claim has been accepted by Medicare for a decision on that claim, okay, and it hasn't been kicked back or rejected back to you with billing errors or submission errors, if the claim is denied, you have 5 levels of appeal, okay? Level 1 is a MAC redetermination. That's with the Medicare administrative contractor. In Texas, the MAC redeterminations must be done through Novitas, okay? So that means you have to have access to Novitasphere to do a level 1 redetermination. Now, most of the time, that's all you need to do is a level 1, but occasionally Medicare upholds their decision, and then you have to go to a level 2, which is a QIC reconsideration. A level 3 is through the Office of Medicare Hearings and Appeals. A level 4 is the Medicare Appeals Council, and then a level 5 is U.S. District Court Judicial Review. And I will tell you that under the chiropractic specialty, it is very rare to go past level 2, because level 3, 4, and 5 assumes a much higher balance on your claims, okay? than we actually have. So very, very rare to see it go beyond level 2. Now, I have done some level 5 appeals in the past, like I did one many years ago on a breast reconstruction. That was for a patient who had reconstruction as part of their cancer treatment, and the payer was trying to not make nice. The Medicare payer was saying, nope, it's not medically necessary. They don't need reconstruction, but it was law, and the MAC kept digging in, and we had to take it to U.S. District Court, and we got it paid, right? So the level 1 MAC is through your Medicare portal. You have 120 days from the denial to submit a redetermination. So you're on the clock, okay? The MAC will then issue a decision within 60 days of the redetermination request. And this is the appeals process summary for all of the other levels. So for the QIC, if you get your level 1 redetermination and it's an adverse adjudication, they say, no, we're upholding the denial, and you want to take it to the second level, you have up to 120 days to submit that one. If the second level denies, then you have up to 60 days to go to the Office of Medicare Hearings, and so on and so forth. So this is just a little guide that gives you the appeals summary. So key reasons for Medicare denials, okay, are as such. HMO plans, the provider's not in network. We already talked about that. There are no benefits if the provider is not in network. Patient is seeking treatment out of their service area. We talked about that as far as HMO plans, and the patient comes to you down in McAllen, and they're from Minnesota, and they have an HMO plan out of the service area. Failure to obtain prior auth, improper use of modifiers, meaning like the GA modifier is not recognized, billing it to the wrong payer. Remember that your Medicare Advantage plans are not secondary to the red, white, and blue. Not billing for covered services when the procedure might be covered under the plan, and always check benefits to see if the patient has a policy with extended coverage. Finally, this is a list of all of the guidance and policies that we talked about today, where this information came from. So remember, you know, in the very, very beginning when we started talking last week, I said, look, this isn't my opinion. None of this is. Everything comes directly from policy. And so, you know, if you're the kind of person that says, prove it, you know, prove it to me in writing, here you go. Here's all of the written proof that you can do. So we are actually at the end of our time, and we timed this out perfectly. So let's look and see if we have any questions, and I'm happy to open it up. We've got about 5 minutes. See if we have any other questions. Thank you very much. I appreciate that, guys. Do we have any hand raise? Okay. So as you know, let's see, we have a few more coming in. Oh yeah, please type in your name and license number before you leave. If you would do that, that's great. That means you stayed the whole time. So these handouts either have been made available to you or will be made available to you. You can email me, or you can email the TCA for the handouts. If you want any of the templates of the ABN forms, you can email me, and I'm happy to send you those templates. If anything I said brings up questions about maybe you're not doing something right and you're not sure, you know, if you are or not, or you know you're not doing something right and you want to fix it, if you need assistance with billing, anything like that, please feel free to use this self-serve scheduling link. to schedule a complimentary consultation with me. There's no strings attached. I don't charge you for any of that. And I'm happy to talk to you about it. Also, remember that we, Gold Star Medical, are your billing and insurance help desk for the Texas Chiropractic Association. So if at any time during the normal course of a workday, you've got an insurance question, you can reach out to us through the TCA. I don't know if you guys have the help desk link on the TCA website. If you do, you can do it through the help desk link. If TCA doesn't have that link up yet, then I would say just email me directly and say, hey, I'm a TCA member and I've got a question for you. Could you help me out? And we're happy to do that. Okay. And we'll keep the TCA notified of any questions that come about and then what our answers are. So thank you, everybody, for your attendance. I know it's been kind of a long 2 Saturday mornings, but you've all been real troopers. And I hope to see you in Lubbock. If I don't see you, we'll see you at another conference soon.
Thank you, Lisa, and thank you, everyone. If you haven't already, please put in your full name and your Texas license number, and we will be sending out a recording and the link to the help desk.
Thanks, guys. Bye-bye.